Oh. Hello, Nick. Uh-huh. Rebooting. The wonders of rebooting. Greetings, everybody. Hey, Nick, how you doing? Oop. My headphones aren't even on. Are you there, Nick? Can you hear me? I guess so. Okay. Hello, Roman. I saw you speak this morning, I think. Was it this morning or yesterday?
No, thank you.
Yeah, you like these webinars.
Yeah, I like very much.
Yeah, I see you a lot.
Yeah.
You're from Czech Republic?
Oh, Slovenia.
Slovenia. Oh, doctor, yeah.
Yeah.
I tried to get a hold of Dolink.
Yes.
We had a conference.
He was my chief for 24 years.
He was what?
My chief.
Oh, wow.
24.
Yeah. He seems like a very nice guy.
Yes.
I got along great with him, and he embraces technology. Of course, he's not up to date, but he still likes it.
Yeah, you're right.
But I just had a hard time connecting with him because most of the older neurosurgeons are hard to connect to. You got to go through the secretary. You know what I mean?
Yeah.
They don't hang around Facebook.
Yeah, it's different world.
Yeah.
Yeah.
Well, we have a panelist from Cuba. Hello, Eddie. Are you there, Eddie? Can you talk? And one from Mongolia.
Wow.
Yeah, it's unusual. I'm trying to get her to do Mongolia Grand Round. Oh, there's Sam right there. There's Sam.
So in my screen, I can't see the participants. Yeah.
Oh, you can't see them?
No.
Well, I could promote you. I'm trying to promote you.
No,
I think you can.
You don't need to. I will be passive, you know?
Yeah. Well, you can still talk.
Yes,
if you have to.
but thank you.
There's Sam. How you doing, Sam? Can you hear me?
Yeah, but okay.
Oh, boy. Your bandwidth is not too good, Sam. Sam? Oh, boy, Sam, your bandwidth is not good. And you've got to announce these guys. Hello, Ahmad. Welcome.
Hello, salam. Greeting. Thank you. How are
Welcome
you?
from Afghanistan, right?
Yes, yes, yes.
Yeah, welcome. We're waiting to have the Afghanistan Grand Rounds
Okay, thank you.
with Ahmad Fad Pirzad presenting.
Yes, yes.
Whenever you're ready. Okay, we're waiting. Let's see, Sam, we have 10 minutes. Sam, are you there? You can hear me? I don't know. Is there anything to do, Sam, about the bandwidth, the connection? Or we're just, I don't know if you can introduce the people. Do you know what I mean?
Yes, Dr. Sameh Al-Mursi Hassan. Salaam alaikum.
Nice to see you.
Okay, thank you. I'm from Afghanistan. And you?
Sam, what are we gonna do? You came to the operating room with a dull scalpel. You're breaking up. The sound is breaking up. I may have to introduce the people, probably not as good as you, but I have the schedule here. Sam? There's no way you can change the connection. Oh, Sam, you want to co-host? Okay, yeah. I think Sam ran to get a good internet connection, which might be hard to do when you're pressed. Hello, Chandra, how you doing? Oh, Chandra's coming in. Oh, Shauna. Hello, Chandra, can you hear me okay?
Yes, thank you, John.
Yeah, hi, welcome.
Hi. I I was a bit confused. I joined at 5 in the afternoon, and I counted the time difference backwards.
Oh, okay. I think you present in about 40 minutes.
Yeah.
Does that sound right, Sam?
Yes. I think half an hour is good.
Okay. Sam, are you there?
I just saw him.
Yeah, he was here. Hello, Dr. Yagmoto.
Hey, John. Good
How
to
you
see
doing?
you.
Nice to
How
see
we
you.
doing?
Thank you for
Hey,
coming.
sir.
Okay, you're second, right?
Yeah, I'm second. And Eduardo Rivas, it's about to connect.
Okay.
I mean, it's like a couple of minutes.
Eduardo's from Brazil, correct?
Yes, sir. Yes,
Yeah.
sir.
You're not in Brazil, are you?
No, I'm in the United States, but I'm from Turkey.
Oh, okay.
John, can you take the Eduardo as a panelist? I think
Yeah. Is he coming
he's
in?
online right now.
Okay. Okay. Yeah, there he is. Okay.
Hey, Sameh.
How are you?
Thank you. How are you doing, sir? Dr. De Pujari.
Yes. Hello.
Hey, nice to meet you, sir. How are you doing?
Nice to see you.
That's a nice background, Chandra. Very
I'm
bright.
getting a wrong background. Yes. Sorry.
Yeah, nice, nice.
Eduardo, how are you doing?
Fine.
Great to see you.
Thank you, Khan. Thank you, Dr. John, for
Thank
the
you. Thank you.
And
It's a
Sameh, let me introduce you to Sameh. Sameh, yeah. And Dr. Del Pujari,
Hello.
Dr. Rivas.
Okay, we got the first three speakers, Sam, right here, sitting right here.
Yeah.
And I got James Leo after that, right?
Oh no,
Right, Sam?
that's another wrong one.
Well, yeah, you can put anything you want there. You can put your hospital, a conference you're running, whatever. And
So we-
eventually, go ahead.
3 minutes to start, John. Welcome all.
It's more directed for a neurosurgical audience, right? Just to check
Yeah.
okay.
Once in a while, patients will come in, but usually you can tell by the questions. You know, wait a minute, this is not an academic question. This is
I
a
think this is
personal
difficult.
neurosurgery question. We can't answer those.
Okay.
You're asking for trouble.
Roman is here. Hello, Roman.
Oh yeah, Roman, he comes to a lot of them. Roman, can you talk? He was here. I was chatting with him initially. Yeah, I've seen Roman at a lot of conferences, but
Hello, everybody. Hi.
There you are.
Hi.
So Matthias, so
Hi.
Sam, you can admit people. I made you co-host.
No, I'm not.
You're co-host, right?
No.
Okay, I made you co-host. Hold on, let me do it again.
Same, you're not heard so well. I mean, we can see you, but the voice is very low.
Is it okay now?
Greetings, Matthias.
Better.
Okay.
Okay, Sam, can you talk again, Sam?
Is it okay now?
Yeah, it's good now. It's good now.
Okay. Okay. Thank
Okay,
you.
Sam, I'll introduce you then, Sam, and then you take over, okay?
Okay, thank you.
Okay.
Hey, Matthias, how you doing? Great to see you.
I can. How are you? Good to see you.
Good to see
Hello,
you.
everybody. Eduardo, John.
Hi, Matthias.
Hello, Matthias, welcome.
Okay, John, we can start now.
Okay, give me a second, Sam. A couple of minutes early, Sam. I got 1:58, Sam. What do you have?
Yep, it's okay.
Just 2 minutes for introduction.
Yeah, it's no big deal. Okay, yeah, that's no problem. Okay, everyone's here anyways. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, home of Neurosurgical TV. Welcome to another collaboration between Neurosurgical TV and the EWNS of Cairo, headed by Samuel L. Morsi. And the topic today is intraventricular lesions. And Sam is going to lead us away. Welcome, Sam.
Thank you, John. Thanks all for joining us today in our neurosurgical approach series. Today is interventricular session, and we will start with Dr. Eduardo Ribas. Please start sharing your screen. Thank you.
Hi, I just began to share my screen, so I think everybody can see now. Sorry about this.
Perfect.
So, okay, to begin with, I just want to thank all the organization for the invitation. Special thanks to Dr. John and Dr. Khan for the invitation. It's a pleasure to be with you. And today I'm going to talk about the anatomy and some microsurgical approaches to the lateral ventricles. So I'm going to begin showing this set of dissections. There is really plain dissections where we did axial cuts of the brain. This is the easier way to prepare the brain, and we can see on these axial cuts that the brain has cavities inside it that we call ventricles. So we have a lateral ventricle inside each of the hemispheres. Then we have a third ventricle that's a single cavity between both thalami. And then at the posterior fossa, we have the fourth ventricle between the pons anteriorly and the cerebellar vermis posteriorly. But that's although it's easy to see the ventricles, it's hard to see the relationship between them. So let's come up with more difficult dissections that we can pinpoint some special landmarks. So this is a superior view of the brain where we have removed the superior part and we are looking upside down to the brain, and we can see that we have two lateral ventricles. These are the big ventricles, one inside each hemisphere, and both are separated by the septum pellucidum, which is indeed formed by two different layers, one on each side, but most commonly they are really attached to one on each other, and we don't have any space between them, any cavum. So this is a more typical brain. And this is a medial view where we can see that the lateral ventricle is mostly covered by the corpus callosum. So the corpus callosum is this fiber pathway there we can see on this we can easily see on this mid section. It has a rostrum, it has a genu, it has a trunk, and it has a splenium, and it covers mostly the lateral ventricle, so one on each side. And then we can see this communication between the lateral ventricle to the third ventricle. This is called the interventricular foramen, or the foramen row. That's going to drain the CSF from the lateral ventricle to the third ventricle. And then from the third ventricle to the fourth ventricle, we have the aqueduct, the mesencephalic aqueduct, that's going to take the CSF from inside the third ventricle to the fourth ventricle. And then from the fourth ventricle, the CSF will get out and open into the subarachnoidal space. I think Dr. Khan is going to pinpoint some anatomical landmarks of the fourth ventricle later. And at the superior view, it's interesting to see that the lateral ventricle makes a C around this block of structures that we call the central core of the brain, but that the most important part is the thalamus. And according to the thalamus, to the position of the lateral ventricle to the thalamus, it has been separated into different extensions or horns of the lateral ventricle. So the part that is anterior to the thalamus, we call the anterior horn or the frontal horn. The compartment that is superior to the thalamus we'll call the body of the ventricle. posterior to the thalamus, we'll call the atrium of the fornix of the lateral ventricle. Inferior to the thalamus, we call the inferior horn or temporal horn, and then an occipital extension we'll call the occipital horn. So let's see one each compartment. This is a superior view, as I said. The frontal horn and the body of the lateral ventricle. These are compartments that are really close to the sagittal plane, so they are really approached by midline approaches that we can talk a little bit about this later, and they are both separated by the septum pellucidum. The lateral wall of these compartments are the head of the caudate and the body of the caudate nucleus. The floor is the rostrum anteriorly, and then the thalamus posteriorly. Since I said the body of the ventricle, it's directly superior to the thalamus. And if we see the floor of the body, it's really important to see this special relation of the thalamus, the plexus, the choroid plexus, and the fornix. These three structures have this sequential lateral to medial disposition, and it's very important for the neurosurgeon to understand, because the choroid plexus is easy to be recognized into surgeries, but then it's hard to see the difference of the color between the thalamus that is lateral from the fornix that is medial. So we have to understand this relationship between these three structures. If we want to get inside the thalamus, we'll be lateral to the choroid plexus. If we want, hardly we want to, but if we want to find the fornix, we'll be medial to the fourth ventricle. For example, if we want to do a transchoroidal approach to the third ventricle, we go a little bit, we go directly medial to the fornix. This is again one anterior view where you can see the veins that are inside the lateral ventricles. This vein is very important to guide the neurosurgeon inside the microsurgical or endoscopic approaches to the anterior horn and body of the lateral ventricle. So between the caudate nucleus laterally and the thalamus medially, we have the thalamostriate vein. This is because it's called the thalamostriate vein because it's between these two structures. And the thalamostriate vein will continue anteriorly and medially, and will join the anterior septal vein and then become the internal cerebral vein, most usually already superior to the third ventricle. This connection can be a little bit posterior to the foramen Monroe, but it's more usually very close to the posterior aspect of the foramen Monroe. This is a more posterior view where you can see again these three structures on this lateral to medial disposition. When we have the lamina fixa, that's the thalamus laterally, then the choroid plexus, and then the fornix medially. And then we can see the body of the ventricle opening into the atrium of the ventricle. And here we can see the biggest volume, the biggest structure of the choroid plexus that we call the glomus of the choroid plexus. This is very important. If you want to, for example, remove the choroid plexus, we'll need approaches that get inside the ventricle, because here's where the most volume of the choroid plexus will be found. Here's a lateral view of the atrium. So we have the glomus of the plexus choroidus, and directly medial to the plexus choroidus, we'll have the fornix. And the fornix opens because it becomes the hippocampus. The hippocampus is seen inside the temporal horn and also inside the most inferior part of the atrium. So this is these well-defined structures whose fibers continue within the fornix. Its fibers are the fornix that continues. So these structures, fornix and hypothalamus and hippocampus, are seen as a continuity of the same structures. Here is the bulb of the splenium. So this is the posterior part of the atrium, and the inferior part of the atrium, and then already at the temporal horn, we have the coronal trigon here. Okay, and the occipital horn is a small extension, a very variable between different people to the occipital lobe. And here we have at the center of the screen, we have the temporal horn harboring the hippocampus inside. As I said, if we see the three structures in this lateral to medial disposition, thalamus, fornix, thalamus, choroid plexus, and fornix, we can understand the transchoroidal approach to the third ventricle. Here I am displacing with my instruments the fornix. What I'm doing is I am enlarging this natural cleft that exists between the fornix that is being held by my instruments and the thalamus, and this cleft is called the choroid fissure. So the choroid fissure can be opened superiorly, what will take the neurosurgeon to the roof of the third ventricle. It can be opened posteriorly to the thalamus also, what will take the neurosurgeon to the pineal region. So we have here at the center of the screen the pineal gland. And it can be opened also at the temporal horn. If we open the choroid fissure at the temporal horn, the neurosurgeon will get inside the lateral wing of the ambient system. So here we are directly lateral to the mesencephalon. And medial and lateral, we'll have here the hippocampus. The hippocampus is a really well-defined structure, different from the amygdala. The amygdala is more hard to identify, especially during a surgery. It's just some gray matter anteriorly and a little bit medial to the head of the caudate of the hippocampus. Some important anatomical landmarks is the special relationship, the close relationship of the foramen Monroe to the knee of the internal capsule. The knee of the internal capsule, the genu of the internal capsule, will have the cortical nuclear fibers that will carry the movement for the face. So if we do a transforaminal approach, for example, endoscopic approach, we have to have a very precise route for this endoscope, because if we harm laterally, we can get inside the knee of the internal capsule. So here we have the foramen Monroe at the center of the screen. Laterally, we have the genu of the internal capsule, and medial we'll have the fornix, its body turning into its column. So its curve is directly anterior and medial to the foramen Monroe, and that's why an endoscopic approach to the foramen Monroe has to be very precise. Lateral, we see here all the layers that make the central core of the brain. This lecture is not about this, but I just want to point that it's really close to this relation. Okay, so the internal capsule is pointing to the foramen Monroe, and the knee is the part that is most close to the foramen Monroe. Also, we have the septum pellucidum, what's called the false septum, because it doesn't have any cognitive function differently from the septal region that's here. So the septum pellucidum can be cut, can be opened into some neurosurgical approaches like septostomy, where we have non-communicating hydrocephalus, and some of our neurosurgical approaches will include communicating both lateral ventricle, and this is done by opening the septum pellucidum. So we have a magnifying view here of the septum pellucidum. So it's spreading from the trunk and anterior part of the corpus callosum to the rostrum of the septum of the corpus callosum, and then to the fornix as well. Here, if we remove the septum pellucidum, we see the lateral wall of the lateral ventricles. This is made by the head and the body of the caudate nucleus. And another interesting anatomical landmark that I want to show is that the internal cerebral veins that will drain, that will receive all the subependymery veins that drain the ventricular cavities, they will join and drain into the internal cerebral vein. And the internal cerebral vein is directly at the center of the velum interpositum, which is the roof of the third ventricle. So whoever is trying to do a transchoroidal approach to the third ventricle will have to remember that you are going close to the internal cerebral veins, and you cannot damage these veins since they will drain all the ventricular cavities, and each vein will receive the basal vein of Rosenthal and then drain into the Galen, the great vein of Galen, and then into the straight sinus. Here is just to pinpoint some anatomical landmarks of the third ventricle. I know my lecture is not about this, but it's important to understand how you will do the transchoroidal approach from the lateral ventricle to the third ventricle. This approach is doing by enlarging the choroidal fissure. So ideally, we recognize the foraminal row, and then we progress posteriorly, opening the choroidal fissure, enlarging from anterior to posterior the choroidal fissure, and then getting inside the third ventricle from its roof, and then inside the third ventricle. The third ventricle opens through the aqueduct into the fourth ventricle, and then into the CSF subarachnoidal space. This special preparation where the ventricular cavities have been filled with liquid metal that was heated, and then later the metal began to be cold, and since it got cold, it got solidified, so now it's solid, and the brain was decomposed later. So here we see where the liquid metal got inside the ventricles, and we can see the shape of the ventricles. And it's important to see how both lateral ventricles describe C's, so two C's arching around the thalamus, but also the central core of the brain. So we can see that the thalamus would be inside this loop, this C formed by each lateral ventricle, one on each side, and the third ventricle is the cavity between both thalamus. So now I'm going to show a little bit about the surgical approaches that the neurosurgeon can do to open the lateral ventricles. So once I said that the lateral ventricle has some medial parts. These are the anterior horn and the body of the lateral ventricle. And these cavities, these compartments, can be approached by midline approaches. These are the transcallosal approaches. Okay, so if you want to get inside the anterior horn or the body of the lateral ventricle, you can do it by going into the interhemispheric fissure and then doing a transcallosal section and getting inside the anterior horn and the body. So you will begin doing a midline craniotomy. You have to face the bridging veins. Of course, they can be a lot of veins draining into the superior sagittal sinus, or we can be just a single vein and a larger vein. But you have to recognize these veins, and you will work into the space between these veins. Then you will gain the interhemispheric fissure, and then open the supracallosal cistern. Once open the supracallosal cistern, you will find the pericallosal arteries and the callosal marginal arteries, and you have to figure out which is the pericallosal artery. This is the one who is directly superior to the corpus callosum, and then you will ideally go between both pericallosal arteries, one on each side, and you will do the callosotomy. Where you're going to do the callosotomy depends where the lesion is. Of course, if the lesion is really anteriorly or posteriorly, you will do the callosotomy directly superior to it. But if you intend to open the third ventricle later, then you need to understand how many centimeters you need to be posterior to the genu. So you can figure out going through the patient's MRI, but it's usually 25 millimeters posterior to the genu. So you can identify the genu and count 25 millimeters posteriorly and do the callosotomy directly superior to the vertical projection of the foraminal row. Another interesting anatomical landmark that you need to remember is that the paracentral lobule is usually 5 centimeters posterior to the bregma. So you need to understand, because you don't want to place your spatula directly superior to the paracentral lobule, because you don't want to cause hemiparesis, directly weakness of the leg, of the lateral leg of this patient. So you need to see where is the bregma and count 5 centimeters posteriorly and save this area by not putting the spatula directly over this point. Okay, this is the point, 5 centimeters posterior to the bregma is the point where the central sulcus projects into the interhemispheric fissure. Okay, so once again, you see the corpus callosum and you make this cut 25 millimeters posteriorly. You can do a little bit anteriorly, a little bit posteriorly, and then you will get inside the lateral ventricle. And directly inside, you can see the foramen row, and then you can make our microscope looks anteriorly and posteriorly to see all the lateral ventricle cavity. Of course, this is a large callosotomy that I just did in this anatomical specimen, but in real surgery, you can just shift the position of your microscope. You can look anteriorly and you can see the anterior horn. So laterally, we have the head of the caudate, and medial, we have the septum pellucidum. Anterior, we have the genu and then the rostrum of the corpus callosum. Between the anterior horn and the body, we have the foramen row, and then at the body, we'll have the thalamus, the choroid plexus, and the fornix immediately. Just want to pinpoint. And then if you want to get inside the third ventricle, you can complete with the transchoroidal approach by moving the by enlarging the choroidal fissure. Okay, I just want to show some other approaches. If you want to get more lateral, for example, to the head of the caudate, you can go directly in the midline, but it would be a long way for you to get more lateral inside the anterior horn. So one other option is to go inside the superior frontal sulcus and then going directly in direction to the anterior horn. Of course, you go first through the U fibers, the short association fibers that are directly underneath the superior longitudinal, the superior frontal sulcus, and then get inside the anterior and body of the lateral ventricle. A chronometric point that you can use is 3 centimeters of midline and 2 centimeters posterior from the coronal suture. This is the point that is the most posterior aspect of the superior frontal sulcus. So this is a nice point for you to understand as the most posterior aspect of this approach. And then you can open the superior frontal sulcus and can get an approach to the anterior horn and body of the caudate of the lateral ventricle. This approach will be lateral to the superior longitudinal fascicle, so you will be free of eloquent fiber pathways, especially if you are dealing at the dominant side. Another very different approach is the transinsular approach, where the neurosurgeon will open the anterior, the sylvian fissure and look for the anterior limiting sulcus. And then if you get inside and deep to the anterior limiting sulcus, you can approach the anterior horn of the lateral ventricle. These are not very usual way of getting inside this cavity, but it's possible because you will be anterior to the head of the caudate and you can get inside the anterior horn, like in this specimen here. Okay, yeah, this is another approach. If you want to go to the atrium of the lateral ventricle, this is a more lateral cavity, so you cannot go into the midline approach. You have to go transparietal. So you will get transparietal through the intraparietal sulcus and then inside the body, inside the atrium of the lateral ventricle. Another possible approach is to go from midline, a parieto-occipital interhemispheric approach, where you remove the isthmus of the cingulate gyrus and get inside the atrium, or you can go transtemporal approach, especially on the non-dominant side, and you can go through the temporal lobe and then inside the atrium as well. To figure out where the intraparietal sulcus is, you will go 5 centimeters lateral to the midline and 6 centimeters anterior to the lambda. This will take you where the intraparietal sulcus joins the post-central sulcus. This is this point here. And then you can figure out that you cannot go anterior to this point because otherwise it will be inside the post-central gyrus. And once identify the intraparietal sulcus, you can get inside and reach the lateral, the atrium of the lateral ventricle. So here's some dissection where we see here the intraparietal sulcus, and if you open this sulcus, you will get inside the atrium. And this approach will also be lateral to most of the superior longitudinal fascicle fibers. So even in the lateral dominant side, in the dominant hemisphere, you can do this approach. And once inside the atrium, you can even go transchoroidal and reach the pineal region also if you want. This approach, the transisthmus approach, I have detailed, is just going into midline and removing the isthmus of the cingulate gyrus and then getting inside I'm just going through, and then getting inside the lateral, the atrium of the lateral ventricle by opening this part of the isthmus here. These are not very usual approach, but it can be done. You can follow the Cochrane fissure, or you can follow the parietal occipital fissure, and then understanding where the isthmus is, and then removing the isthmus and getting inside the atrium as well. I'm just going to finish my lecture talking about the transtemporal approach. So you can get inside the atrium as well by going through the transtemporal approach, especially on the non-dominant side, because here will be the Wernicke area, and you will, but also in the right hemisphere, you will have to go through the geniculocalcarine fibers. These are the optic radiation. So if you're going transtemporal to the atrium, you will always harm visual fibers radiations. So you will cause hemianopsia to this patient, but some will go into this approach. And just to end, the approaches to the temporal horn, if you can go laterally or directly into the inferior limiting sulcus. And of course, you have to understand the position of all these fibers, especially the uncinate fascicle, inferior fronto-occipital fascicle. They are superior and lateral to this to the temporal horn of the lateral ventricle. Okay, sorry about the time. I just wanted to show you, if you can see this dissection and this paper that I wrote. Okay, once again, thank you for the invitation. I know it's a long, it's a lot of information to give in 20 minutes, but I hope I could show some of the microsurgical approaches to the lateral ventricle. Thank you.
Thanks a lot, Eduardo, for your illustrative, excellent presentation. Is there any question from panelists? Okay, thank you, Eduardo, again. And now we will shift to the next speaker, Dr. Ken. Please start sharing your screen. Thank you.
Thank you. It was an excellent talk. Let's make sure. Dr. John, can you see the full screen?
Not yet.
No?
Not
Yes,
yet.
yes.
Yeah, now it's, yeah, yes, no,
You can see the full screen, okay.
yes.
So now I would like to talk about, today I would like to talk about the microsurgical anatomy of the fourth ventricle. It's always pleasure and honor for me to be a part of this great team, and thanks for having me here. I'm gonna do so we will discuss the floor of the fourth ventricle first, and then the internal structures underlying the floor. Then finally, we will see the roof of the fourth ventricle, and finally we will see the surgical approach to get to the fourth ventricle. Now we are looking at the rhomboid shape of the floor of the fourth ventricle. Here we see the midline, median sulcus that divides the floor into two depaired halves. And the prominences here is a facial colliculus and the lower part, we see just next to the median sulcus is the hyperglossal triangle, vagal triangle, and that colorful area is the area postrema. This lower part appears like a pen-nib shaped, so also called as calamus scriptorius. So what else we see here? We see also lateral recess of the floor, and another sulcus is a sulcus limitans, and just a lateral sulcus here, and deepens at 2 points. The first just lateral to the facial colliculus, called superior fovea, and the second one just lateral to the hyperglossal triangle, which is called inferior fovea. Those are important landmarks on the floor of the fourth ventricle. So superior fovea, which is a dimple of the sulcus limitans, has a triangular shape. The superior lateral edge is formed by the superior cerebellar peduncle. Inferior lateral edge is formed by the vestibular area, and medial edge is a sulcus limitans. The triangle is a landmark for estimating the structures in the brainstem. The superior lateral edge here, so the trigeminal motor nucleus sits deeper point of the superior lateral edge of this triangle, that we don't want to mess this part. Also, the facial colliculus can be seen only 60% of the cases. So the top of this triangle is the same transverse level as the upper part of the facial colliculus. If the facial colliculus is invisible, we can find the top of this triangle, and we can estimate the upper part of the facial colliculus. So the structures underlying the floor. The solid structure in the brainstem is a trigeminal nerve that gives off the spinal trigeminal tract, descends to the spinal cord, and the trigeminal mesencephalic tracts ascends up to the midbrain. And just next to midline is we see the medial longitudinal fasciculus. And here's a central tegmental tract that interconnects with the olive, with the red nucleus, and is a part of the extrapyramidal system. So all the structures are located lateral to the sulcus limitans here. In other words, if we need to enter to the brainstem on the floor of the fourth ventricle above the facial colliculus, if we keep staying between the median sulcus and the sulcus limitans, which is called median eminence, it's relatively safer area to stay and get into the brainstem. And of course, the abducens nucleus and the intrapontine segment of the facial nerve form the facial colliculus. So the fourth ventricle is a passage for the CSF that's circulating inside and has some connections. The fourth ventricle connect with the aqueduct, connect with the third ventricle via aqueduct. And the fourth ventricle connects with the central spinal canal via obex, and with cisterna magna via the foramen magendi, and we see the lateral recess here, and with its connection with the CP angle, cerebellopontine angle, via the foramen luschka. If you follow the lateral recess, like in this picture, all the way laterally, we can reach to the foramen luschka, which is located in front of the flocculus here. And sometimes the fourth ventricular tumors also follow that the way and comes out to the CP angle. So the fastigium means the highest point. The highest point of the fourth ventricle is here, fastigium of the fourth ventricle. And here's the superior half, and here's the inferior half of the roof of the fourth ventricle. The superior half is formed by superior cerebellar peduncle, superior medullary velum, and inferior half formed by the nodule in the midline, and we will see inferior medullary velum and the telechoroidea laterally. So now in the next slide, we are going to look at this wave from behind. Here we see this is the superior half, and here's the inferior half of the roof of the fourth ventricle. The superior half, laterally superior cerebellar peduncle we see, and in the midline we see the superior medullary velum. In the inferior half, here we see the inferior medullary velum, and here's a telechoroidea. So inferior medullary velum arises from the nodule, sits in front of this membrane, and the inferior medullary velum is a neural membrane that connects with the nodule with the flocculus, extend laterally to the flocculus, and is a part of flocculo-nodular system. If you come down a little bit, we see the telechoroidea, in which the choroid plexus arises, and also this attachment of the telechoroidea here is called a tania. And the lateral recess is covered by the inferior medullary velum and the telechoroidea. These two membranes extend on the both side to side here. So, and also what else we see here? We see the tonsil, which is very important, the structures for surgical approach. Here is a dentate nucleus. It's kind of like head of the tonsil here. We don't want to mess with this dentate nucleus during the surgery. And here is in the midline, what we see here, this is the uvula here, and this is the tonsil. We just pass between the uvula tonsillar, the fissure, which is called uvula tonsillar fissure here. What we see here, we see the inferior medullary velum, and here's a telechoroidea, and here's a forma maganda, by the way, which is the connection of the fourth ventricle with the sternum magna. And when we open this part, this membrane here, we can get access to the fourth ventricle, and it's called as the televelar approach. Telechoroidea and inferior medullary velum has a junction, televelar junction. When we open this membrane to get into the fourth ventricle, is called televelar approach. So let's navigate the fourth ventricle within the cerebellum. This is a lateral view. What we see here, this is the dentate nucleus. And cerebellum has three peduncles, by the way. The superior cerebellar peduncle, inferior cerebellar peduncle, and the middle cerebellar peduncles. So what we see here, this is inferior cerebellar peduncles, comes from the spinal cord, ascends up, and passes on the dentate nucleus to reach the vermis of the cerebellum. Now we remove the inferior cerebellar peduncle, and here we see the superior cerebellar peduncle that arises from the dentate nucleus. And as we said, the superior cerebellar peduncle is the lateral wall of the upper half of the ventricle. Also, we can see here is the ventricle is here right now. So if we remove this superior peduncle, here we see the nodule, which is like a light in the room. And finally, we see the superior cerebellar peduncle here, and inferior cerebellar peduncle also forms the ventral, the lateral wall of the inferior half of the fourth ventricle. So this is another view. So just remove the tentorial part, tentorial surface of the cerebellum to expose this dentate nucleus here. Now we are looking from behind. Here's a tonsil again. Superior to the tonsil, we see the dentate nucleus. And the midline, what we see here, we see the uvula. This is in the midline, inferior vermian structure. So again, this is inferior cerebellar peduncle, passes on the dentate nucleus, and his superior cerebellar peduncle is here. The rest of the white matter of the cerebellum is the middle cerebellar peduncle, is the largest peduncle, and the rest is the middle cerebellar peduncle. So what else we see here also? Here we see the nodule, and in the midline, this is uvula. Just remove the inferior peduncle. Nodule is here, the flocculus is here, and the inferior medullary velum extends from the nodule, also arises from the nodule, till to the flocculus, which is a part of flocculonodular system. In the midline, again, we see the uvula here. And of course, the both side dentate nucleus. So its injury may cause the intentional tremor or nystagmus. So that's why we always want to keep away from the dentate nucleus of this approach. So the surgical trajectories for the lesions located aqueduct, sometimes we can come from above, but of course, you know, the surgical approach to the fourth ventricle is a suboccipital midline approaches. Let's briefly see the surgical approach from above. We can either transcallosal, interhemispheric transcallosal approaches. These dissections, one of my fellows is the dissections, the Dr. Ilgaz from Turkey. We can either use anterior interhemispheric approach or posterior parieto-occipital interhemispheric approach. So here we see the both fornices retract laterally, and we are looking at the velum interpositum, which is the roof of the third ventricle. Now, finally, we can get into the third ventricle. Here's a posterior commissure. Just below the posterior commissure is going to be aqueduct. So what we done here by now, we passed along to the interhemispheric fissure, cut the corpus callosum to get in the lateral ventricle. There is a 3 options to reach the third ventricle. Dr. Ribas already mentioned about it. We can either come subchoroidal or transchoroidal or interfornical approach to get into the third ventricle. When we get to the third ventricle, here's the aqueduct, and here we see the floor of the fourth ventricle. We can reach the aqueduct here. So the major approach is a suboccipital midline approach. When we do the craniotomy or craniectomy, we have 2 options, which is televelar approach or transvermine approach. Of course, is a televelar approach is more commonly used, and each approach has pros and cons. The televelar approach, we use the natural clefts and the membranes, which lacks the splitting of the brain tissue. And the transvermine approach, we cut the inferior vermis to reach to the fourth ventricle. That provides slightly better exposure to the superior half of the ventricle, but the televelar approach provides a better exposure to the lateral recess. So for the transvermine approach, we cut, here we see the nodule again, here, and this is the uvula, and here's the pyramid. So for the transvermine approach, we cut the pyramid, uvula, and nodule to reach to the ventricle, and especially, you know, the superior half of the fourth ventricle. For televelar approach, we use the tonsil, and here's uvula, and this is the tonsil here. We use the cleft between the uvula and the tonsil, and here, and we can have better access to lateral recess of the fourth ventricle. The problem with the transvermine approach, that when we cut this all, you know, and here, let's see again. I can also explain here too. Here we see the uvula. This is the pyramid here. So if we need, you know, when we pass between the uvula and the tonsil here, we can reach, we can have also upper half of the fourth ventricle and the lateral recess access to the lateral recess. But when we cut the uvula and the pyramid here and the nodule, that's called the transvermine approach. The problem is when we cut all this brain tissue, that can cause the caudal vermis syndrome, which is some equilibratory problems. So that's why the televelar approach is preferred over the transvermine approach. Of course, dealer's choice. So this is the target area, and we use a suboccipital midline, craniotomy or craniectomy. And open the dura, letter shape or Y shape, depends on the surgeon. And here we see uvula and the midline and the both tonsil. That mimics the oropharynx, the same. Uvula is the midline and the both tonsil on the sides. And here we see the floor of the fourth ventricle. So that exposure we get after suboccipital, the midline craniotomy or craniectomy. We see the both tonsils on the sides, and here's a uvula again. When we just separate the fissure between uvula and the tonsil, we can see the televelar, the membrane is here. Of course, we always want to be careful about the medial trunk of the pica, and this vein is a branch of the vein of the cerebellomedullary, the fissure. So here is a tania, and usually we have the choroid plexus here. If you follow the choroid plexus laterally, we can also reach to the foramen luschka in that part. And finally, this is the full exposure. Of course, this is cadaveric dissection and remove the tonsils, and we can see a full, we have the full exposure of the floor of the fourth ventricle, and that part is the facial colliculus. The further information can be found. This the brainstem surgery book, and the animations from this book is made in the Barrow, and the dissection. All the dissection is made in our work. Thank you.
Thanks a lot, Ken, for this excellent presentation. Is there any question from panelists? Okay, thank you, Ken.
My pleasure. Thank you.
And now we will shift. To next speaker, Professor Dojari. Thanks a lot for accepting our invitation. Please start sharing your screen.
Okay, perfect. Chandra, you were on full screen, but you changed back. He may have slipped off, Sam.
Professor Dojari, do you hear us?
Yeah, he's trying to get on now. We'll just wait. Well, Chandra, you need to screen share your PowerPoint, not the Zoom. Are you there, Chandra?
Yeah.
Okay.
Is it seen now?
Yeah, we see the PowerPoint. Now just put it on presentation mode.
Okay.
Yeah.
Fair enough. Can you see it now?
Yeah, perfect.
Okay. So thanks, Same and John for this opportunity. And my job is, of course, made easier by the earlier talk by Dr. Ribas. And I'm going to mainly talk about the lateral and third ventricular tumors and my experience over last 20 years using microsurgical and endosurgical approach. I think we all know that almost 90 years ago, there were books on benign tumors of the third ventricle, and Walter Dandy had published almost 30 articles talking about various approaches. Some of them are prevalent even today. And then Dr. Apuzzo, Dr. Alroton, and Dr. Yasargil in the last 35, 40 years have made this much more popular, describing the microanatomy and the various surgical corridors, which were beautifully described during the last talk. So when we are treating a patient where our treatment is aims at relief of hydrocephalus, which is one of the manifestations of many of these tumors, and it is challenging mainly because of difficulty in accessing the various areas of ventricle through eloquent areas, as we have seen. Another thing is, of course, the location of the vascular pedicles and occasional attachment to the ganglionic and mesencephalic structures. And the microsurgical strategies depend on anatomical consideration to minimize these risks, especially to cortical and subcortical structures. Endoscopic approaches avoid that, but we need to then be careful about not hurting the blood vessels, etc., which will disturb our not only the trajectory, but even the vision, because we are working in a fluid field space. So we actually analyzed our 247 patients operated till 2018, and about 247 patients were operated during this time. About 85 operated with endoscopic, either endoscopic approach or endoscope assisted approach, and other 161 patients with microsurgical approach. And we've added another 40 or so cases with it. One of the things about the intraventricular tumors is, if you know the age of the patient and if you know which part of the ventricle is involved, invariably you can probably talk about the diagnosis as soon as you look at the image. And in our experience, these are the various pathologies which were seen, colloid cyst being, of course, the most common, but several others, including some rare inflammatory lesions as well. So let us talk about the transcortical approaches. We have seen which are the safe corridors to grow. Should we be using a transsulcal approach or a transcortical approach is always something which is debated. If you want to make a big corridor, probably you are better off taking off a little bit of cortical surface and increasing this. Most of the people who are working even with tubular retractors are doing that now. But in a smaller lesion, you can probably go to the depth of the sulcus and do it in a non-eloquent area. One of the most common tumors you encounter, especially in young patients, is a neurocytoma. And there is a talk specifically on this tumor later on. This is a 38-year-old man. You can see a large lesion occupying the lateral ventricle, almost near the foramen of Monroe. Some of it is going into the third ventricle. Ventricles are slightly large. One of the considerations I use for deciding on transventricular, transcortical or a transcallosal approach is that if you have some kind of a fluid cap over the lesion, then it becomes much easier to do it by a transcallosal approach. But whenever it has, there is no space between the ventricular wall and the tumor, or occasionally it has some parenchymal encroachment, then it is much better to use that trajectory to approach the tumor, which is what we did in this patient. The other thing which we do is we make a small opening with a needle and then inflate that opening with the use of this inflatable simple handmade device using a glove, and that allows us not to disturb the fibers too much. So this is the patient being a small corticectomy being done, and then we have started removing this tumor. A piecemeal removal is being done. The vessels are being gently coagulated, and we are taking the tumor away from the ventricular wall as we go along. And the beauty is that as the ventricles becomes, and towards the end of this procedure, I always use the endoscope to make sure that we have achieved good hemostasis and most of the tumor has been taken out and there are no hidden clots, which has allowed us to use external ventricular drainage much less frequently, and the post-operative hematoma and requirement of EVD has gone down considerably. We close this gap by something like a cigarette of gel foam and use some glue over it. And this is a 3-month post-op scan which shows a complete excision and the patient recovered well without any neurological deficit. The other sort of rationale for using a particular approach, apart from just the location, is where the tumor blood supply is coming from. And this is especially important in vascular lesions like choroid plexus papilloma or a meningioma. And this is a typical example of a meningioma, which is usually situated in trigone. This patient presented with headaches and later on with mild dementia, and that is when we decided to go for surgery. So we were just talking about the parieto-occipital approach, but I favor a little posterior, that is the, we're talking about interparietal approaches, but I prefer to use a parieto-occipital approach because it is easier to go to the pedicle of the lesion by using this approach, and optic radiation is also much less disturbed. And we gently lift this up and you will find it just to get a proper trajectory. I would use either navigation or occasionally we use ultrasound. I'm doing a transsulcal here. And once you reach, we try to go underneath this. Sorry, I'm getting some signal on my screen which is not allowing me to progress faster. One of the important things is, as soon as you get to the edge of the lesion, try to use cotton plate. Do not allow the blood to sort of spread in the ventricular system, because the bleeding point can be a little out of your vision and you can get the whole ventricle filled up with blood without realizing, and the brain can start bulging. So all the time keep on packing the area as soon as you remove the tumor from that area. And this is how we achieve a complete excision, as you can see. And this is the post-operative scan at 3 months. In terms of colloid cyst, which is one of the most common examples, and about 85 patients out of this series are colloid cyst patients, you can use any of these approaches, either a transcortical, transcallosal, and endoscopic, and I'll show you small examples as to when we use which approach. So this is one of the patients. One of the problems I initially had, of course, was whenever you have a T2 dark lesion on the colloid cyst, which usually means that it is probably inspissated or almost a solid kind of material within the cyst. That I found as one of the problems. Here you see that the fornices are almost completely covering this lesion, and the lesion is slightly posterior to the foramen of Monro. So in this patient, I decided to actually use a transcortical approach. As you will see that the foramen of Monro is hardly seen, and you are not seeing the cyst quite well. So we are now opening the choroid fissure, and then we start seeing the cyst. It is being splayed further, and now you start seeing the cyst. The attachment near the venous angle is being cut. You're opening this choroid fissure a little further to get to the back of the cyst wall. And then eventually the blood supply is being completely cut. And this is something I find occasionally difficult. We will talk about that when we talk about the endoscopic approach. So you can see how the foramen of Monro has been dilated without damaging the internal cerebral vein, and we have got a complete excision of this cyst. Problems reported with transcortical approach are seizures, occasional hemiparesis or hemianopia, depending on which area of the corpus callosum you have disturbed, and subdural effusion remain common, probably a little more common in transcortical approaches than transcallosal approaches. However, more and more reports of large number of patients are showing that seizures are probably equally common in transcallosal as well as transcortical approaches, and you have to really choose which approach depending on the size of the ventricles and location of the tumor. interhemispheric transcallosal approach was extremely popular when we were residents, and we used to not only learn and use it in as many cases as possible in the early part of our career. And one of the reasons for that, of course, is that the access to lateral ventricle traverses only a small area of commissural tract, and usually an opening of 10 to 15 millimeters is enough and carries a much lower risk. And typical examples are low-grade gliomas, which are near the foramen of Monro. And I think whenever there is a CSF cap seen above the tumor, you are quite safe to use the transcallosal approach to get to the lesion. This is one of the pilocytic astrocytomas which has been taken out. Third ventricular tumors can also be taken out safely. This is a ependymoma, which was completely excised using a transcallosal approach, as you can see here. However, the problem comes is when you have a lesion. We were discussing the colloid cyst earlier with large ventricles. This is a colloid cyst again, a darker colloid cyst, posteriorly situated colloid cyst, and the size of the ventricles is very small. And here, should it be removed or not is another question. So this article describes which cases should probably be operated, which has higher risk scores. And the cyst was just about 7 millimeters and situated in the posterior aspect. So we decided to go ahead, and I removed this with a transcallosal approach. So you open the corpus callosum about 1.2 centimeters between the two pericallosal arteries. And then you see I have had to do a subchoroidal approach even in this patient, as the foramen of Monro was not widened at all. And now you can start seeing the cyst once that subchoroidal approach is widened to about 0.5 centimeter or so, and the cyst could be then completely removed. You try not to empty the cyst fully so that you have something to hold properly and it doesn't fragment frequently. And this is the post-operative scan in this patient. We have written that sometimes it becomes necessary to use this kind of approach, especially in a posterior located cyst, or if the fornix has some variations. And this is another case where we had to do this kind of a surgery. And one more case where the cyst was situated much more posteriorly. Of course, apart from the other aspects of transcallosal approach complications, you can get, if you have sacrificed one of the major veins, you can get a venous infarct, which happened in one of our patients. Fortunately, this settled down nicely, apart from some seizures in the first 2-3 months. But the hemispheresis and seizures are much less common, at least in individual papers which have come out from various. Endoscopic approach has given us a large benefit, especially in cystic lesions and in some tumors as well. It also gives us an opportunity to relieve the hydrocephalus by performing simultaneous ETV or septostomy. It allows you a better assessment of spread by seedling, etc. Allows devascularization of the tumor, allows tumor excision either directly or with assisted surgery. And most importantly, it also helps us in inspecting completeness of excision and hemostasis. This is one of the lateral ventricular cysts where double fenestration is very important, as with most other cysts, and this patient settled down nicely. In colloid cyst also, whenever the situation is favorable, like in this particular patient, we have been able to do this. We coagulate the pedicle and then use sharp dissection to cut it off, aspirate the cyst a little bit with this ventricular catheter, and then try to excise this. Though we have found that you may occasionally leave a small remnant of the cyst wall near the venous angle. What about the solid intraventricular tumors? It is difficult. I think performing a biopsy is easy. Performing suction decompression, when the tumor can be shrunk with suction, which cannot be so commonly used in the channel endoscope. So endoscopic assisted procedures are mainly performed in these kind of situations. except for this new device which has now come to our help, which is like a channel CUSA. And we acquired this Zuring CUSA, which we have used in a few cases, usually not very large patients, very large tumors and relatively avascular tumors. So this is a low-grade glioma, mainly involving the septum in the frontal region, dilating the ventricles a little bit. And you can see it as soon as you enter the ventricle. And this, we are first taking a biopsy. This proved to be a pilocytic astrocytoma. And we decided to go ahead with the use of this CUSA. This CUSA has an end cutting device, unlike the Nico Myriad, which has a side cutting kind of an edge, but it works very well. It delineates the tumor from the ventricular wall quite nicely. As the wall is collapsing, you can see that the difference between the ventricular wall and the tumor is becoming more and more prominent. And eventually we managed to excise this tumor completely. This device gets blocked very often, and we have found that it requires frequent servicing. So we have not used it in as many cases as we would have liked to use, but this has been quite successful in excision of some low-grade tumors like this one. These are the post-op scans, and this is what I was talking about, these two devices. And Dr. Chinali is later going to talk about his experience. He's got probably the largest experience now using this kind of a device for solid tumors. If you look at this paper by Capabianca with combined experience of several departments, he says that the ideal tumor for endoscopic resection is tumor with low vascularity, soft consistency, less than 3 centimeters diameter, associated hydrocephalus, low histological grade. I think most of these are still true, but probably larger tumors can be operated. Unless they are very vascular, I think you can use this device quite satisfactorily. As far as the posterior third ventricular tumors are concerned, I think there is almost now a uniform agreement that if there is a hydrocephalus, most patients will first go endoscopic third ventriculostomy and biopsy and collect CSF for tumor markers before we consider radical surgery, as almost 2/3 of the patients can be treated with adjuvant therapy alone, especially in young patients. This is our experience. This is one of the young child, about 2 years, who presented with raised intracranial pressure. And we have been able to, you can see a largish tumor in the pineal region. And we first performed the third ventriculostomy. And you can start seeing the tumor here right away. So after performing a third ventriculostomy, we just turned the scope 180 degrees, went to the back and started taking biopsy of this lesion. And this turned out to be actually a ATRT and went for adjuvant treatment straight away. I think there is a safety and diagnostic accuracy of neuroendoscopic biopsy is quite well recognized. We have had about 87% diagnostic accuracy and more than 80% success rate in our ETVs. Only 2 patients required subsequent shunts. Sometimes the problem comes with thick massa intermedia or if the lesion is vascular. And this is one of such patients where we had very thick massa intermedia. After performing the third ventriculostomy, we found that when we turned the scope behind, we could not actually see the lesion quite well. And we had to go above, with another burr hole, we had to go above the massa intermedia. You can see the thick massa intermedia here, and then go for the tumor. And this turned out to be a malignant parenchymal tumor and was treated with radiotherapy later. Another thing is you can actually get a better assessment of seedlings, which were not seen even on MRI. So you understand the extent of the lesion much better by doing endoscopy in such patients. As far as assisted surgery is concerned, I have used it endoscopy to coagulate the, this kind of choroid plexus papilloma. I have initially gone and coagulated the whole blood supply before we started excising the lesion, and it worked out quite well. And we also used it towards the end of the procedure just to make sure that proper hemostasis is achieved and the whole tumor has been excised at the end. We actually use a transparent tubular retractor. This kind of a tube, which is very easy to prepare either out of a syringe or out of any kind of cylinder. Midas Rex drill bits come into this. We have used those as well. So we are not using a branded tubular retractor, but are doing tubular retractor surgery as and when required through a transparent sheath. And this is one such example. It has also been useful to use, endoscopic assistance for a case like this. This is a patient with a epidermoid. Patient had partial relief of hydrocephalus with shunt done outside, and we decided to go ahead with a supracerebellar approach. This is the top of the head of the patient. This is the cerebellum, and you can see I'm separating it from the tent without enlarging the opening very much, without putting a retractor. We are trying to get to the lesion. We have just about got to the lesion. Without putting self-retaining retractor, you start removing this lesion, and the suction is gradually taking it off. And then rather than enlarging the opening or putting in a retractor, we decided that we'll use endoscope to get the deeper portion of the lesion because we wanted to clear up the aqueduct. After this large chunk comes out, then I think we start using the scope. And once you have done that, you can see that you certainly don't require much more retraction, and you can take out the small pieces which were strategically placed at the opening of the aqueduct without hurting the surrounding veins. Occasionally it can be difficult, and you may have to use a self-retaining kind of a device to stabilize these retractors and then work with two hands. But most of the times a free hand surgery works here. So the whole posterior third ventricle has been emptied, and this has been complete excision has been achieved. So this is our experience using endoscopy and microscopy. As I told you, about 160 cases with pure microscopy, and over the last 5 years, several cases with endoscopic surgery. We have been able to do endoscopic surgery alone for excision in only about 7 patients. Most of the time it has been endoscopic assisted excision, and some of the cases are mainly cyst fenestrations, endoscopic biopsies. And the other use we have found is whenever we are in doubt, we will do an endoscopic biopsy, and if it turns out to be a benign lesion, which we think we can excise completely by another open operation, we'll proceed with that. The complications have reduced considerably, especially in terms of delayed ventriculoperitoneal shunting, which was required only in 3 out of these 85 odd patients, and intraventricular bleeding requiring any kind of drainage later on was only in 2 patients. So these were the main advantages. I would just like to show you an interesting case before I stop talking about it. This was a 2-month-old child where we first performed a biopsy, because choroid plexus tumors in such small children can be choriocarcinomas, but this turned out to be a papilloma. We thought the child was too small to sustain surgery and put a shunt and came out. But this shunt actually caused ascites in this child, And when we put a peritoneal drainage tube, it was draining more than 200 to 300 cc's every day. And eventually we had to, just because of the increased CSF production, we could not continue to use the shunt, and we had to take the shunt out and remove this child's tumor at the age of 3 months. Luckily, everything went well, and the child is doing now well for 2 years post-surgery. So this is just a summary of our experience. I think microscopic approaches are important. Endoscopic approaches have occasionally been useful by themselves, but it has made a great difference in terms of assisted procedures, giving us biopsies, etc. And proper utilization of both these have reduced the complication rate in intraventricular tumors, and certainly allowed us to remove the tumors much more radically. Thank you.
Thanks a lot, Professor Debujari, for this excellent presentation and the great experience that you gave us today. Is there any question from panelists? Okay, there's a question in the chat box asking about the difference between endoscopic controlled and endoscopic assisted surgery.
So,
Dr. Samay, can I give a small comment on the presentations?
Okay.
I know
Okay.
I'm,
Okay, go ahead.
you know what, I'm enjoying. Here it is past midnight at almost 1 o'clock here in the morning in Mumbai. So I will give a little bit brief comment on intraventricular tumor surgery. You see, intraventricular tumors are more often benign in nature, relatively benign. They are benign, they are large in size because they grow in size, there is space, and they become very large and huge before they are diagnosed. You talk of neurocytomas, central neurocytomas, you talk of intraventricular meningiomas, you talk of ependymomas. Even ependymomas in the ventricle are relatively benign tumors. You talk of central neurocytomas, if you remove them, they are quite benign. You talk of meningiomas. You talk of majority of intraventricular tumors are benign in nature. The problem is that to approach these tumors is because they are in the center of the brain, we have to approach with difficulty and with fine microneurosurgical style and techniques, as Dr. Dev Pujari was mentioning. There are several routes. We have to select the best and the safest route. More important is we have to save the fornices, which are very important in memory. So it is a high, precise, technical neurosurgery. And those who are doing it, and also many of these tumors are very highly vascular in nature. So I have enjoyed my journey with intraventricular tumors and large intraventricular tumors. And recently I wrote one article on large intraventricular tumors, which probably is the largest series in the world. And, you know, we have to be prepared for good results. We have to be prepared for disasters. In short, intraventricular tumor surgery. Dr. Samay, you have chosen a very beautiful title, beautiful topic. And more importantly, I enjoyed the beautiful anatomical lectures which were there today before Dr. Dev Pujari's lecture. And those lectures, I think, is a big property of your channel, of your show today. And I hope and I wish that you all enjoy these presentations, which are from very high profile neurosurgeons of the world. And my best wishes to you, Samay, and for your team. Thank you very much.
Thank you
Thanks,
again,
Abdul. As for the answering this question is concerned, I think what I would say is that when you talk about endoscope assisted technique, we are talking mainly about microscopic surgery, and we use endoscope to, you know, see something hidden behind or something which helps us to remove the last bit of tumor, like I showed in the epidermoid case. While endoscope controlled surgery is something like what we did for the colloid cyst, that you may use an outside channel instrument, but the surgery remains almost completely endoscopic. or for that matter, what we do, pituitary surgery, I would say that we can call endoscopic controlled surgery. So that is the essential difference as per the original kind of classification given by Axel Pernesky and his team.
Thank you, Professor Dubujari. Professor Ibrahim, you
Hello.
can ask your question.
Thank you very much indeed. Hello, Samah. Hello, John. Hello, Chandra. Hello, everybody.
Hi.
Hello, Atul. It's as Atul said, it's almost midnight here in the Middle East. It's Ramadan. We just broke the breakfast, so one is relaxing at home. So it's nice to see you all. I want to ask Chandra and the other panelists about the safety of travel by air for those people with colloid cyst and hydrocephalus.
Sorry, Ibrahim, are you asking me about safety in colloid cyst surgery?
Safety to travel by air for a patient with a colloid cyst and hydrocephalus.
Oh, seriously, I do not know about it, but I think unless a patient has had craniotomy, it should not really matter too much. I mean, we have some data about subarachnoid hemorrhage, but I am not sure we have anything about colloid cyst. Somebody else may be able to answer.
What about Atul? Are you there, Atul?
Yeah. I'm not sure, Ibrahim. This is a wonderful question. I don't think I have ever imagined this question or thought about it. But whether travel will lead to alterations in intracranial pressure dynamics and whether presence of colloid cyst will alter that dynamics, I am not sure. But if the colloid cyst is reasonably large, or even if it is little bit large, or even if it is small, I will say I will prefer to take take it out, because the surgery has become so much safe with the, with fine microneurosurgical techniques, with knowing how to operate and what to do. The surgery is quite safe. So better to remove it rather than leave it to cause a disastrous situation. What is your experience?
You have
Ibrahim?
any experience in this, Ibrahim?
Well, yes, and there were a few papers about the safety of travel with a patient with colloid cyst and hydrocephalus. I think it was an Indian patient to start with who was in India and wanting to go back to his work in Dubai, and then he lost consciousness on board, and the whole story. I'm raising these questions for the purpose of, suppose somebody called you, Chandra or Atul, that they have a patient in another country, and they describe that he has an interventricular tumor with hydrocephalus. Would you advise them to treat the hydrocephalus before they travel or not? That's the question.
My answer to that question is very clear, Ibrahim. I will not touch the hydrocephalus. I'll remove the cyst.
I mean, they're not with you. They are coming to you. People are calling you to come to you. Would you advise them to treat the hydrocephalus?
No.
Knowing that in that country, they may have put a shunt, and the shunt is going to be permanent.
I don't like.
I have not done so in my own practice. I mean, they have been flying out of some other cities in India, which are like a couple of hours travel by flight, and I have not refused them. But your question makes me think.
Thank you, Anwar. Thank you. The other point about why is it that damage to the thalamostriate vein will cause disasters in some surgeons' hands, and in other hands it causes nothing? Is it a technical difference? Is it what kind of
anatomy? I think our
anatomy?
anatomist can tell us that, but something like a dominant thalamic vein or more than one thalamic vein is not commonly described as far as I know. So why is there a difference like this in behavior of different patients is something maybe Dr. Ribas can tell us.
Sure.
Excuse me, can I talk? Hello?
Okay, go ahead.
Hello.
I'm sorry, the
Go
connection's
ahead,
not
please.
good, Sam. Let's move on, please.
Hello, can I talk?
Okay, the connection's
Okay,
okay
go
now.
ahead.
Go ahead.
Thank you, and hello for everybody. Regarding the question from Dr. Ibrahim, what about, I'm not a consultant yet, but I have an idea. What about if the patient is getting in a bad situation from the hydrocephalus, but he had a colloid cyst? What about if we did an emergency EVD and then we operate, close it before the operation, few days, so the ventricles will be dilated, or a few hours, so it gives us more chance to remove the tumor in a dilated ventricle, and then we will do, remove the EVD. Do you got my answering? Is it right or wrong? Just to know what is my thinking is scientific analyzer or not?
If the patient has reached our department with a hydrocephalus in a bad situation, I would still go for the cyst first. I may come out leaving a drain in such a patient probably for the next 24 hours, but I'm not going to go only for a EVD. If I'm operating on this patient, I would go and remove the cyst.
I mean, as Dr. Ibrahim said, you are in another country or far away until you come before the patient deteriorates from the hydrocephalus. If we did EVD and covered with antibiotic, just close it one day or a few hours, 6 or 12 hours before the surgery. Is it a bad idea or a bad scientific analysis, or it's still not capable to do this approach or this maneuver? I mean,
I am happy for other people to answer, but my answer to this question is when you have a lesion at the foramen of Monroe, and if you do EVD on one side, you might occasionally get one ventricle collapsed, another ventricle dilating to such an extent, and the ICP may still, continue to progress. So it doesn't solve the problem for a substantial length of time. It may be better to remove the cause rather than, or if you are going to do that, I would probably do a septostomy in addition to that. But maybe Dr. Chinali can answer, or anyone else can answer.
Chandra, I think that it's always keep the good sense as the first logic is the most important thing. If the patient is so sick that he cannot be moved, that he's already vomiting and in severe troubles of consciousness, of course, he requires life-saving procedure, even a double external drainage, and then let him survive, and then check what is going on. You can have, you certainly have seen much more than me, colloid cysts coming in with an extreme compromission of the consciousness. This patient require emergency treatment wherever they are. I think that the most important things concern about the troubles in the airplane are about hemorrhage. That means aneurysm can bleed, and there are isolated reports of intracranial masses discovered during flights that bleed, or because some patient with a significant residual or recurring tumors are reaching an area where they have to do some kind of palliative treatment. This is described. So I think that the main risk of traveling in the airplane is the hemorrhage, and the colloid cysts do not bleed. So if the patient is in good condition, just some headache and no other problems, I think that if he can take the first flight and go to Mumbai or wherever and be operated in a 2-3 hour setting is much better for him than taking an ambulance and doing maybe 800 kilometers by ambulance. I mean, good sense must remain our best friend.
Right.
Thank you all for this great discussion. And now we will start the next lecture. Please, Professor Sinali, start sharing your screen. Thank you.
Thank you very much, Sameh. Can you hear me loud and clear? Well?
Yes.
Okay, is the screen shared?
Not yet.
Not yet. Okay, sorry. Desktop. Oh, sorry, this is the very first time that I'm using this computer. This is brand new, so I have to I have some.
Can you see the screen share option?
Yes. The problem is that they open to me a safety and privacy option. And
Oh, okay.
oh,
Well,
okay.
Take your time. Take your time.
Okay.
Sometimes you have to
Wait a
work
second.
through
I
them.
think I got it. Wait a second.
Yeah, okay.
Sorry about that. Oh, I have to get out of the webinar to authorize Zoom to use the. Sorry, give me just 5 seconds. I will get out and I will rejoin. I'm very sorry about that. I'm sorry.
No problem.
Okay.
Okay, Sam, I'll introduce some notable people in the audience while we're waiting. Abby Shah is here from Mumbai, India. Hello, Abby. Are you there, Abby? You can introduce yourself while we're waiting. How about Dr. Kabulo
Hello,
from the
Avida.
Congo? How are you? Geez, no one's answering me, Sam. I know, I think Abby's there. Go ahead, Abby.
Avida is muted.
Everybody's
Vlad is
muted.
here, I saw.
Hi, John.
Oh,
Hello,
there you
sir.
go, Abby. How you doing?
I'm fine.
Welcome.
Yeah. Nice
Okay.
presentations.
Yes. Yes. Dr. Kabulo, are you there? You want to introduce yourself? If you're there, you may have stepped away. And we've seen Dr. Sabea and we've seen, how about Roman? You want to say hello, Roman, to the audience? Hey, Sam, I'm getting shut out.
Yeah.
Here we go. Hey, Roman.
Yeah, I must say that I'm enjoying this topic very much.
Okay, here I am.
Welcome back.
Thank you.
Can I talk?
Yes.
Yeah.
Okay, sorry about
okay.
that. This is the very first time I use this computer, so it's a problem of authorization
No,
of
it's okay now.
Zoom to share the screen. Okay, thank you for giving me the opportunity to share our experience of pure endoscopic management of intraventricular tumors. It's always difficult to talk after Chandra Diopijari and Dr. Ribas. I will try to do my best. I have no disclosures. As said and cited by Chandra with the paper from Cappabianca that we contributed to produce, the limitation of the traditional endoscopy in intraventricular tumor removal are the fact that a pure endoscopic procedure is difficult because of small working channel. The instruments are necessarily small because they have to fit inside the working channel. Frequently a long and boring procedure with frequent blurring of vision and traditionally reserved to a lesion of less than 1.5 2 centimeters of diameter or more frequently. With the production and presentation by Ertel of this device, things started to change a little bit in 2008. They introduced this device with this paper on Journal of Neurosurgery. They presented some experimental data on the pig's brain and a very limited clinical experience mainly on intraventricular and intracerebral hematoma. But after this first presentation, the many years of silence started because there were some problems with the confidence in this instrumentation that could fit only through the largest working channel existing on the market, that was the GAB endoscope. Until 2013, where in the group of leads from Paul Chumas and Atul Tyagi, the first case finally of tumor completely removed through this approach with a pure endoscopic procedure was described. It was a very, very small lesion in the distal part of the aqueduct that was approached with a very anterior bowel hole through the foramen of Monroe. And this is the vision at the end of the debulking with the device, with a complete removal of this low-grade glial tumor. So it was a very, very first case, and we started to use that in approximately in the same period in 2014, and we accumulated a little bit of experience until 2017, where we presented our paper. And now, then after that first presentation came other papers from the group of the Spanish group from Professor Miguel Angel Arraez, who also presented a nice series of patients, and also the group of Soleman in Basel. So papers are starting to multiplicate, mainly limited to relatively small tumors that do not push really very much the indication, the original indication of intraventricular tumor. And even this very last group from the Naples region also present one single case of a low-grade ependymoma of the pineal region. In our experience from 2013 to 2021, we did 36 surgery in 28 pediatric cases. 25 were purely intraventricular, 3 were paraventricular, and 8 were suprasellar tumors. Histology is mainly glial tumors, craniopharyngiomas, choroid plexus papilloma, SEGA, and OPG, and other miscellaneous histologies. The surgical approach was mainly precoronal, a standard precoronal bar hole for lateral ventricle region tumors, or for third ventricle region. 31 cases, the approach was precoronal, always dictated by neuronavigation, but mainly precoronal, 4 parieto occipital, and 1 very, very anterior frontal approach. Surgical technique is dominated by the necessity of a continuous irrigation with a warm ringet lactate by a simple gravity without any peristaltic pump to avoid a risk of excessive increase of intraventricular pressure. Low aspiration power is usually mandatory in order to avoid the risk of excessive drop of intraventricular pressure. We usually use an aspiration power that never exceeds 20%, but usually can be set between 10 and 15%. It is largely sufficient because the bleeding is frequently very small, limited only to the area where the cavitron tip is working, and this is largely sufficient to keep a relatively clear CSF and working media. The cavitation power adapted to the tissue instead can be variated very significantly according to the stiffness and to the texture of the lesion, ranging from 20 from low grade, very soft glial tumor, up to 80–90% with the calcified tumor or calcified craniopharyngiomas in the third ventricle. And then the most important thing in this device that we are using is the direct control of the suction tube with the possibility of immediate clamping. I do not rely on the pedal. I ask an assistant to be there to clamp immediately with his hands the suction tube when I realize that I am approaching too much, or that I have captured some big vessel inside the aspiration cannula. My assistant must be ready to clamp immediately the aspiration tube in order to avoid or limit the risk of injury to big vessels. These are the very few elements of the setup. This is the GAB endoscope that is not produced anymore. This is a problem commercially, but can be overcome with a recent device. And this is the device of ultrasonic aspirator. This is how the whole thing is set up. It can be used with one single hand, but certainly for longer procedure, a holder, mechanical holder, is largely desirable and very, very effective. In my experience, this is the bar holder. Mechanical pneumatical holder is fantastic. I introduce the trocar inside the ventricle under navigation. I remove the stylet, and I introduce the optic, and then I adjust my trajectory, and then I include my ultrasonic aspirator inside the endoscope, I adjust my trajectory, and this is the assistant that can clamp the tube immediately. And this is the setting, and this is myself working with a tumor of the region of the foramen of Monroe. Tips and tricks. It's important to keep the suction cannula always occluded by tumor tissue to decrease the CSF aspiration in order to, as I was saying before, limit the risk of excessive drop of intraventricular pressure. It is, you must keep in mind that this is an aspirating device, that especially if the ventricles are small, there is a risk of ventricular collapse, and ventricular collapse brings the risk of remote subdural hematoma, acute subdural hematoma. This never happened to me, but the theory, of course, is very well known. So this is how we use when we introduce our endoscope inside the ventricular chamber and we see the tumor. We start the irrigation in order to have always a warm Ringer lactate, keeping the ventricular cavity large. We approach the device to the tumor and we occluded our aspiration cannula with the tumor, and we start with the ultrasonic cavitation of the tumor at this level. Cavitation after cavitation, seconds after seconds, the tumor fragments are aspirated inside the cannula, and as well with the debris produced by the device. And there is a good balance between irrigation and aspiration, because the irrigation is balancing very well the very, very small amount of CSF that is sucked through the cannula that is partially occluded. And so our endoscopic ultrasonic aspirator can progress in the depth of the tumor, keeping always the tip occluded. But when this is interrupted and I go back with my aspirating cannula, then of course I start to aspirate a lot of fluid from the ventricular chamber, and the irrigation fluid is not able to keep a balance anymore. And this should never happen. Either at this point you stop the aspiration, because at this time you have a ventricular collapse and you have fluid aspirating too much. Then it's better to touch again the tumor, interrupt your aspiration of fluid, and so the irrigation will restore the normal and positive intraventricular pressure and restore a working channel. In tumors of the third ventricle like this one, this certainly is facilitated by very, very large ventricle for a chronic hydrocephalus. You see the tumor that is bulging inside the foramen of Monroe below the thalamus striate vein. Calcified core, very densely calcified core inside the third ventricle. So we started to think that this was not a very good indication. The tumor could have been too hard. In fact, entering into the lateral ventricle, we had the surprise to find a very soft part of the tumor bulging inside the lateral ventricle. So we started with great confidence the aspiration of this very soft tumor that very quickly can be aspirated with a relatively small bleeding, as you can see. The quality of the vision is excellent at this point. We are aspirating the part that is occluding the foramen of Monroe. You see that the very few drops of blood are not obscuring our vision. We remove completely the part of tumor that is bulging inside the lateral ventricle. You see that my cannula is not moving very much. I just wait for the tumor to be aspirated inside. We have to remember that behind us, we are inside the frontal lobe. And here we are entering into the third ventricle. This is the calcified part of the tumor. The bleeding is a little bit more pronounced, but keeping the endoscope very close to the tumor, we can see very well what you are doing, and we can work in a small chamber environment as described by Henry Schroeder, and we can remove also the calcified part. You can see very well the calcified tumor that is in front of us. These very small pearls are all areas of calcification, and at the end of the tumor removal, we can have a free third ventricle with a very, very small remnants just lying below the two internal cerebral vein. And even the calcified core, as you can see, is being completely removed by pure endoscopic surgery. These other cases, this was our very first complex case of a very large para and intraventricular tumors too close to the corticospinal tract to be operated with a transparenchymal route. It was too posterior, and so we decided for a parieto-occipital approach. This is a vision from behind. you can see that the tumor is in a ventricle that is not very large. Fortunately, the tumor was extremely soft and not bleeding very much, and we were able to recognize it very well bulging inside the lateral ventricle. And as you can see, the bleeding is very limited and very easily controlled by the aspiration. Here you recognize more and more the normal cavity of the lateral ventricle, and recognize the tumor tissue that is bulging inside it. And as we progress, we can see that the ventricle is more and more free of tumor. And this is the area of the paraventricular and of ventricular and of parenchymal infiltration of the tumor. We are removing here the upper part that is bulging inside the tumor. We stop the surgery at 50% removal, waiting for the histology, and then after 3 weeks approximately, after a low-grade glioma histology, we reoperated the patient, and in the 2 surgical procedure, we were able to remove it completely. This is the upper part, and as you can see, the limits are very well visible, the bleeding is very limited, and this is the area that is infiltrating the parenchyma, and that we decided to remove with another procedure 3 weeks later. And this is the final cavity of the lateral ventricle after the first procedure. So this is the pre-op, and this is after the second procedure with a very acceptable removal. Another case that you can see occluding the left foramen of Monroe. Here you can see isolated, there is already an external drainage and septostomy performed in emergency because of monoventricular hydrocephalus. And this is after the surgery with a complete removal of this foramen of Monroe ganglioglioma intraventricular, very strange histology, intraventricular ganglioglioma. Tuberous sclerosis are excellent indication. Tuberous sclerosis can provoke unilateral hydrocephalus, occluding the foramen of Monroe. In this case, as you can see, the ventricles are not very large, and this can make the surgery relatively more difficult, a little bit more complex if compared to very large ventricle. You can see that with the aspiration, you have a collapse of the ventricular cavity. After removal of the central part, we go back. Here we are working inside the trigon of the lateral ventricle. This is the posterior pole of the tumor that is progressively aspirated by the ultrasonic aspirator. Then we progress anteriorly after removing the posterior pole, and you can see that we are looking for the thalamus striate vein that we must respect. Of course, you can see that we can dissect the tumor from the thalamus striate vein that you can see here very well, and even this dissection can be extremely precise, almost as precise as with microsurgical instrumentation. And then we break in two completely the tumor. We realize where the foramen of Monroe is in the most anterior part. We remove the most lateral part that is attached to the head of the caudate nucleus. You see that after complete devascularization, the removal is very, very easy, of course, because there is no more bleeding from the lesion, and you can see very well the foramen of Monroe that is completely free of tumor. And this is the very last removal of the last remnants of the tumor that are attached to the lateral wall of the ventricle. And you can see that you just have to follow your tumor and to remove it completely. And this is the postoperative MRI showing that the right tumor has been completely removed. The left tumor was left because it was stable. And of course, we have to limit our indication only to what is strictly necessary in tuberous sclerosis. In craniopharyngiomas, also very good indication, especially if a large cyst is associated with a significant nodule and the calcified nodule. These patients are not a good indication for intraventricular intracystic interferon because of the very large solid part. And in these cases, of course, when there is a hydrocephalus and menacing the vision with a papilledema, of course, we treat the cyst and we restore CSF circulation inside the ventricle. Here you can see that we aspirate completely the content of the cyst after coagulation of the choroid plexus. We can recognize very well the attachment of the tumor at the level of the hypothalamus. We must avoid, of course, the section of the areas that is close to the hypothalamus. Here we are removing the part of the cyst that is floating inside the third ventricle. The cyst wall is very hard, it is calcified, but you can see that our ultrasonic aspirator can suck and destroy completely this, remaining well away from the ependyma and without touching minimally the ependyma, and we can have a very good partial removal of this tumor, addressing this patient finally to radiotherapy as stated by the guidelines that are nowadays relatively accepted of not touching the tumor of the part of craniopharyngioma that is infiltrating the hypothalamus. So we left a small residual that was addressed by radiotherapy. This is the pre-op and this is the post-op. In other cases, like in this case, also there was a significant nodule at the level of the hypothalamus with a much larger cyst, and we were able to be more aggressive. This is again the cyst wall that is completely aspirated, and not a single drop of motor oil is contaminating in this phase the lateral ventricle. We aspirate as much motor oil fluid as possible through the cannula. You see that I'm not moving my cannula in order to keep the hole very small and aspirating all the possible fluid. And you can see that after opening of the cyst, the motor oil fluid is not disturbing your vision. We remove progressively the part of the tumor that is floating inside the third ventricle. You see the calcification, the typical standard appearance of a craniopharyngioma. We are approaching the infundibular area. We are removing as much tumor as possible. And of course, we were able, in this case, very lucky to remove completely the tumor, even the calcified nodule that was at the level of the hypothalamus. This was a previous case if compared to the previous one, pre-op and the post-operative case. In optic pathways gliomas, we have very recently published our experience of endoscopic ultrasonic aspiration as an alternative to more invasive surgery in the initial management of OPG. 4 cases with 5 surgery, because 1 case was operated twice. Our aim in the OPG, of course, as you all know, is just to clear the CSF pathways, remove, debulk the tumor a little bit to get an histology for a molecular typization and genetic typization, and avoid the CSF shunt. And this is what we do in this case. We do the biopsy of the tumor through the foramen of Monroe, and we start to aspirate with the ultrasonic aspiration the OPG. You see that is relatively friable. They are bleeding tumors, but they can be aspirated quite well if you stay very close to them. At the beginning of the surgery, the bleeding can be more intensive, but after you have removed 30–40%, the bleeding is decreasing a little bit and you can progress more. In this case, we are progressing inside the tumor, and our aim is to destroy the most posterior part. This is the massa intermedia. We are working inside the third ventricle, and I am looking at this time for the aqueduct of Sylvius in order to be sure that the fluid, CSF fluid, can circulate properly between the foramens of Monroe and the aqueduct of Sylvius. And now I can see finally the aqueduct of Sylvius here ahead of the massa intermedia, and I am sure that I can stop my removal because the CSF circulation is restored. This is the pre-op and this is the post-op. You see that there is a surgical corridor created between the foramen of Monroe and the aqueduct of Sylvius. Another view of the same case, pre-op and post-op. And in other cases, we do much more generous removal. In this case, we can arrive to up to 70% of the tumor removal by simple endoscopic removal. And this is the best results, 71% of tumor mass removal removed by pure endoscopic ultrasonic aspiration. This is another case, pre-op in the MRI, and this is the post-operative MRI. You see that significant tumor mass removal after pure endoscopic aspiration. Choroid plexus papilloma also are very good candidates. It is a typical case of choroid plexus papillomas. The trick is to coagulate them with a monopolar or bipolar, or we prefer to use the laser in order to reduce the bleeding as much as possible, and also because the coagulation allows a significant shrinking of the volume. You can see here that I am coagulating, and as soon as my coagulation progresses, more tumor comes into vision around the boundaries of the foramen Monro, and after my coagulation phase, you see that the tumor is much less vascularized, it is deflated, and I can remove that with the endoscopic ultrasonic aspiration very well, and the bleeding that otherwise would be much more important is relatively limited. The vision is acceptable until the very end of the lesion. Certainly, there is still need for a lot of irrigation in this phase, and this is the very, very small residual part of the tumor that is attached to the telachorioidea, and we can remove with the ultrasonic aspiration until the very, very last remnant of the tumor. You see that you can go to catch for it just below the posterior edge of the foramen Monro, and this is the free third ventricle after tumor removal, and this is the post-operative. This is a small clot that is inside the third ventricle, but the removal of the tumor was absolutely complete in this case. Alternatives to the cavitron exist in the United States, and more recently in Europe. The nycomyriad has been presented and described for the removal of craniopharyngioma, also very large craniopharyngioma like in this case. The nycomyriad in this movie taken from YouTube, you can see that it is a side cutting bayonet device that is an aspirating device. It aspirates the tissue, tumor tissue inside this side opening, and then there is a bayonet cutting device that mechanically aspirates and cuts and destroy the tumor, and it is probably a little bit less elegant than the previous one, but it seems that it is very effective. I was saying that it is now impossible to use the GAB endoscope because it is not produced anymore by stores, but there are being two changing, and the device has been adapted to the large Esculap Invent endoscope that is available on the market. This is the Invent endoscope, and we can put the new device inside the working channel, and we can use the device in this way. You can see that it is not more bulky than the GAB endoscope. Here is the setup completely organized, and in this case of optic pathways gliomas, we were able to decide to remove only the most posterior part, because the most anterior part was still infiltrating some of the connectomic areas of the hypothalamus. So we decided for a limited approach to the posterior third. And in this case, we had a very bleeding tumor that was bleeding, very vascularized. So we had some initial troubles in keeping a good vision. As you can see here, the time is excessively spending in keeping the water fluid. So we decided to remove the CSF and working in a dry field. This is our fourth case of dry field experience. In this case, you can see that you can remove a significant amount of tumors without any troubles, because the bleeding is really very, very limited. This is the anterior pillar of the fornix delimiting the foramen Monro. We are removing nicely this tumor. We are progressing with this removal, going below the anterior pillar of the fornix and chasing the tumor that is hiding until the anterior commissure, and then we progress with our tumor removal inside the third ventricle, and you can see that we can really do a very, very nice job. And after we have removed a significant part, then we can go back in our diving technique, refilling the ventricle and exploring the posterior third ventricle, seeing the aqueduct, and continue our removal. And you can see that the bleeding is now much more easy to control, and we can remove much better the floating part of the tumor that is kept in movement by the irrigation fluid. And with these very small tricks, we can really progress very nicely. And in 2-hour surgery, we can really do a nice job if compared to much longer in our hands transcallosal procedure that takes certainly more than 2 hours from skin to skin. So this is the final result of this tumor, more than 60% of removal. And this is our results in 25 complete removal, 7 planned partial removal, and 4 enlarged biopsy. We are now writing a paper where we are calculating the percentage of the volume in cubic centimeters in order to better define our indications. The remarks are that the procedure is easier in larger ventricle, but is possible in normal ventricle under navigation control and continuous irrigation, and strict control of aspiration power, of course, is of utmost importance. Complications were 1 subdural hygroma treated by subduroperitoneal shunt. In conclusion, the patients harboring intraventricular tumors are in most cases ideal candidates for endoscopic biopsy and resection. Endoscopic cavity is very effective in selecting indication. There is a potential to expand indication to pure endoscopic resections, and specific training, of course, is necessary to use this device both for endoscopy and also in addition for use ultrasonic aspirator dedicated to endoscopy. Thank you very much.
Thanks a lot, Professor Sinali, for this excellent presentation. Is there any question from panelists? I think it was so clear, dear Professor, and it was a great pleasure to have you today and to listen from you this excellent experience. Thank you, sir.
Thank you very much.
And now we will shift to next speaker, Professor James Leo.
Okay, Sam, we got the video.
Okay.
The introduction is there, Sam. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. We have a pre-recorded broadcast from James Leo for a conference that Samuel L. Morsi put together for the 16th of April, and today's the 14th, and James has been good enough to take the time to pre-record it. And I'll let him take off in his presentation. Welcome, James, and thank you.
Great. Thank you, John, and thank you, Sameh, for this very kind invitation, and congratulations on all your efforts in global neurosurgical education. It's a real honor to be a part of this. Let me go ahead and share my screen. Are you able to see that?
Yes, perfect.
Okay, great. So today I'm going to talk about the interhemispheric transcallosal interforniceal approach to the third ventricle. And I title it The Road Less Traveled because it's a route that not too many people take because of the fear of forniceal injury. But I want to show you some tips and tricks and operative pearls where you can do this safely and avoid any injury, and how to use this to your advantage within your armamentarium in treating third ventricular tumors. The third ventricle is located deep within the brain, and it's surgically difficult to access. It's impossible to remove masses without violation of some tissue involved, and currently there's no consensus on the best approach. There are generally two schools of thought in terms of visualization. There's the microscope, and then there's the endoscope. The endoscope techniques are thought to have slightly lower rates of post-op morbidity, but there's certainly higher rates of tumor recurrence. And the microsurgical techniques are more invasive, but have a lower incidence of tumor recurrence. This is a systematic review we published some years ago showing endoscopic versus microsurgical resection of colloid cysts. The microsurgical group had higher gross total resection, lower recurrence rates, and lower reoperation rates, but the overall morbidity was lower in the endoscopic group. And within the microscopic group, transcallosal had lower morbidity rate than transcortical approaches. So when we talk about microsurgical resection, how do we get down into the third ventricle? Well, you can go transcallosal interhemispheric, which is a natural corridor, and the only tissue you divide is the corpus callosum, whereas the transcortical approach, you go through the cortex of the brain, which can have a higher incidence of postoperative seizures. And then once you get down into the lateral ventricle, there's generally 3 ways to get to the third ventricle. You can go through the foramen of Monro, which is transforaminal. You can open that area using a transchoroidal, either above the choroid or under the choroid. And then you can go down the middle, which is interforniceal, and go between the leaflets of the septum pellucidum, between the fornices, and drop down into the third ventricle. So I want to focus on the interforniceal approach. These are some diagrams showing access. This is dropping into the third ventricle. This is the view that you get in the right lateral ventricle. The way you orient yourself is you look for the choroid plexus. It's like the yellow brick road. You follow the choroid plexus and it takes you to the foramen of Monro. You then identify the septal vein along the septum, the thalamostriate vein laterally, and the fornix. And when you see these structures, this confirms you're in the right lateral ventricle. So this is the transforaminal route. You can access the foramen of Monro if the foramen is dilated from chronic hydrocephalus. This is a useful avenue, but it can be limited, and you could injure the fornix if you're trying to deliver a large tumor and the fornix is under stretch or from surgical manipulation. You can open up that corridor using the transchoroidal route, and the 2 ways of doing it are either suprachoroidal or subchoroidal, where you incise the tilia choroidea, and it can widen this transforaminal corridor and get you to that anterior third ventricle. And here it is showing how you can do that. And lastly, the interforniceal approach is the route where you go between the leaflets of the septum and then divide these attachments between the fornices and drop into the third ventricle. Here you see on these diagrams a lot of use of retractions, and this is something that I don't recommend. What you also see in this diagram is this is done in the supine position, and so the head is pointing north, the nose is pointing north, the back of the head is to in the bottom of the screen. And when you're using retraction, you have a higher risk of forniceal injury. And again, here is the interforniceal approach using a right lateral ventricular access. And here are some Roten diagrams again showing the interforniceal approach and the different variations. And this is the view that you get once you open up the velum interpositum and drop into the third ventricle. You'll see the internal cerebral veins and the medial posterior choroidal arteries. Historically, this was initially described in 1944, and it was utilized in 6 patients that had 2 mortalities. It was further described in Dr. Apuzzo's book, Surgery of the Third Ventricle, and it's gotten a lot of criticism over the years, mostly because of the incidence of memory deficit. In a review in the literature, there was the incidence was about 36% of memory deficit. So how can we avoid forniceal injury? How can we make this surgery safer and more effective? And should we abandon the interforniceal approach altogether, as some may have proposed? This is an older series dating back to July 2017. Since then, we've probably added another 10 to 12 cases or so. But at the time of this review, we looked at 16 cases where we did the interfornicele approach. We generally do them in the lateral position, and the lateral position allows us to use gravity assistance, which allows the dependent frontal lobe to fall away from the falx and also allows the fornices to open up as well. So the lateral approach gives us this midline view, and we're able to see both walls of the third ventricle, unlike the transforaminal or transchoroidal approaches that views the third ventricle in an oblique angle. So this is the general positioning. We'll put the patient in the lateral position, a coronal linear incision, and one of the important nuances is to position the bed and the neck so that the falx cerebri is roughly about 30 degrees from horizontal. What this allows is it allows the dependent frontal lobe to fall away and allow the surgeon to have the line of sight down the interhemispheric corridor. So this is the general angle that you want to have. I make the craniotomy directly over the superior sagittal sinus, where we cross the midline to the other side. This allows you to reflect the dura and actually retract the superior sagittal sinus by a few millimeters, which really makes a difference in really giving you that maximal access to the interhemispheric fissure. We have to preserve the bridging veins. Occasionally you can encounter bridging veins here, and you have to try your best to not sacrifice these and work around it. You may have to extend the craniotomy a little bit more anteriorly to do that, but again, try to preserve these bridging veins to avoid a venous infarct. When you're in the lateral position, the frontal lobe falls away nicely, and the interhemispheric fissure is very easy to open sharply. The brain falls away, and you quickly find the pericallosal arteries within minutes. And look for the white, shiny white tissue, which signifies the corpus callosum. If it's yellow and it's not white, you're probably in the cingulate gyrus. But look for the white color of the corpus callosum, and then you can spread the callosal arteries laterally, making space to now do your callosotomy. We use image guidance to confirm which trajectory to drop into the lateral ventricle. But the callosotomy in general is about 2 to 2.5 centimeters, which is adequate to treat a lot of these lesions. Again, you can use the choroid plexus to determine the laterality of the ventricle. And then we then perform wide fenestration of the septum pellucidum. So now you have equal access to both ventricles. Another technical point is that when you're working in the lateral position, you generally have a better view of the contralateral lateral ventricle, which is the ventricle that's situated on the top side, the contralateral side. And this is due to the lateral position and gravity assistance, where the brain generally falls down. So how do we define the interfornicele plane? So if you look at this diagram here, you notice how there's these fimbriae more posteriorly, and the fornices are more adherent anteriorly. So I generally start opening posterior to anterior, and I use very gentle, fine microbayoneted forceps, and you spread interpositum and drop into the third ventricle. You'll see the internal cerebral veins and the medial posterior choroidal arteries. Historically, this was initially described in 1944, and it was utilized in 6 patients that had 2 mortalities. It was further described in Dr. Apuzzo's book, Surgery of the Third Ventricle, and it's gotten a lot of criticism over the years, mostly because of the incidence of memory deficit. In a review in the literature, there was the incidence was about 36% of memory deficit. So how can we avoid forniceal injury? How can we make this surgery safer and more effective? And should we abandon the interforniceal approach altogether, as some may have proposed? This is an older series dating back to July 2017. Since then, we've probably added another 10 to 12 cases or so. But at the time of this review, we looked at 16 cases where we did the interforniceal approach. We generally do them in the lateral position, and the lateral position allows us to use gravity assistance, which allows the dependent frontal lobe to fall away from the falx and also allows the fornices to open up as well. So the lateral approach gives us this midline view, and we're able to see both walls of the third ventricle, unlike the transforaminal or transchoroidal approaches that views the third ventricle in an oblique angle. So this is the general positioning. We'll put the patient in the lateral position, a coronal linear incision, and one of the important nuances is to position the bed and the neck so that the falx cerebri is roughly about 30 degrees from horizontal. What this allows is it allows the dependent frontal lobe to fall away and allow the surgeon to have the line of sight down the interhemispheric corridor. So this is the general angle that you want to have. I make the craniotomy directly over the superior sagittal sinus, where we cross the midline to the other side. This allows you to reflect the dura and actually retract the superior sagittal sinus by a few millimeters, which really makes a difference in really giving you that maximal access to the interhemispheric fissure. We have to preserve the bridging veins. Occasionally you can encounter bridging veins here, and you have to try your best to not sacrifice these and work around it. You may have to extend the craniotomy a little bit more anteriorly to do that, but again, try to preserve these bridging veins to avoid a venous infarct. When you're in the lateral position, the frontal lobe falls away nicely, and the interhemispheric fissure is very easy to open sharply. The brain falls away, and you quickly find the pericallosal arteries within minutes. And look for the white, shiny white tissue, which signifies the corpus callosum. If it's yellow and it's not white, you're probably in the cingulate gyrus. But look for the white color of the corpus callosum, and then you can spread the callosal arteries laterally, making space to now do your callosotomy. We use image guidance to confirm which trajectory to drop into the lateral ventricle. But the callosotomy in general is about 2 to 2.5 centimeters, which is adequate to treat a lot of these lesions. Again, you can use the choroid plexus to determine the laterality of the ventricle. And then we then perform wide fenestration of the septum pellucidum. So now you have equal access to both ventricles. Another technical point is that when you're working in the lateral position, you generally have a better view of the contralateral lateral ventricle, which is the ventricle that's situated on the top side, the contralateral side. And this is due to the lateral position and gravity assistance, where the brain generally falls down. So how do we define the interforniceal plane? So if you look at this diagram here, you notice how there's these fimbriae more posteriorly, and the fornices are more adherent anteriorly. So I generally start opening posterior to anterior, and I use very gentle, fine microbayoneted forceps, and you spread. And you can do this by spreading the leaflets of the septum pellucidum superiorly above where the two fornices meet, and then you can slowly open that area and look for the clear membrane of the velum interpositum. So these are the layers you want to look for. You look for the two fornices, and as you're spreading the two fornices carefully, you're going to encounter an arachnoid membrane. That's the tela choroidea, which is the superior membrane. Then you're going to encounter a space, which is the velum interpositum. It's a potential space that houses the internal cerebral veins, as well as the medial posterior choroidal artery and its branches. And then below that will be another membrane, which is the inferior membrane of the telochoroidea. And then once you open that, you'll see the choroid plexus and drop into the third ventricle. So this is the exposure showing the tumor exposed into the third ventricle. And then here we're removing the cyst. And then here's the final view showing the choroid plexus. Here's the foramen of Monro, nicely opened. And then here's the other foramen of Monro. There's the third ventricle. And then here we've left a ventricular drain in the resection cavity. And so this was a colloid cyst. This is the pre-op. This is the post-op. You can see the direct interhemispheric access. And this patient was neurologically intact and back to work within 6 weeks. Here's another larger tumor. This is a colloid cyst that underwent a shunt at another hospital. They did not attempt to remove it, but you could see the colloid cyst has enlarged significantly, filling up the third ventricle. And so we did this in the lateral position, interforniceal approach. Craniotomy, it extends across the midline. You can see by gravity assistance, the frontal lobe falls away. We can incise this arachnoid, which is on stretch, very easy to open using gentle spread techniques with sharp dissection, identifying the pericallosal arteries. We then divide the pericallosal arteries and look for that white tissue, that is the corpus callosum. And then we can use image guidance to plan our trajectory, make our callosotomy about 2 to 2.5 centimeters. We've dropped into what appears to be the right lateral ventricle. There's the old shunt catheter. And we're going to look for the two fornices. And there's the cyst presenting itself to the foramen of Monro. And it's quite large, so it's hard to deliver through the foramen of Monro. But now we've opened up the interforniceal fissure. There's the cyst. And we're going to start draining the cyst so we can collapse the cyst to allow us to dissect around it. Now, those are the internal cerebral veins posteriorly. There's the medial posterior choroidal arteries. And as we continue to dissect around the cyst will eventually release itself of the contents as we dissect around it. It's important to maintain as much turgor on the cyst as much as possible. You don't want to drain it too early because this turgor gives you that surgical handle. And once we come all the way around the cyst and free it from all the critical structures, we can begin to deliver the cyst carefully. Here's the last medial posterior choroidal feeder. There's often adherence to the vasculature, some arterial feeders you have to divide. And you can see if you did this endoscopically, this would be very hard to remove completely, but with microsurgical techniques, we can remove this completely to prevent future recurrence. There's the cyst, almost 3 centimeters. And there's the floor of the third ventricle. We're fenestrating it to make a third ventriculostomy. There's the basilar artery. And so we're going to open up everything to improve CSF circulation. There's the two fornices intact. There's the floor of the third ventricle. And this is the final view. You can see complete removal of the cyst. And she was neurologically intact, no memory difficulties whatsoever, and went back to a normal life. Here is another patient. She presented with acute hydrocephalus and underwent Takotsubo's cardiomyopathy. This is a complication of ICP-related stress. She was unable to tolerate surgery at first, so she underwent a shunt, and then we came back for definitive removal at a later date with a complete removal, memory intact, and back to work. Some people have advocated for cyst aspiration for colloid cyst, and this simply doesn't work. You drain the cyst, but because of the cyst walls present, it will continue to secrete and grow. And so this patient underwent definitive surgery with an interforniceal approach, and we were able to get a complete removal here. What about solid tumors? This approach I think is useful in solid tumors as well. This is a central neurocytoma of the third ventricle. More uncommon, they're usually lateral ventricular tumors, but occasionally you can have a third ventricular presentation. This is the post-op scan. And then what about the posterior third ventricle cavity? We can use the interforniceal approach to get to the pineal region tumors as well. And this is a recent publication that we published in Neurosurgical Focus. This is a 69-year-old male who presented with hydrocephalus from this posterior third ventricular lesion. We initially did an ETV and a biopsy, which came back as papillary tumor of the pineal region. These are benign tumors, and the recommendation is surgical resection. When we think about the surgical approaches to the pineal region, we can consider the supracerebellar infratentorial approach, the occipital interhemispheric transtentorial approach, a posterior precuneal interhemispheric approach, or we can go anterior interhemispheric transcallosal. Now in this case I chose the interhemispheric transcallosal mostly because the tumor presented itself to the posterior third ventricle, and you have a wide access to this region. Again, you can go through the corpus callosum, and instead of going to the anterior third ventricle for colloid cysts, you can angle your microscope and your callosotomy more posteriorly, and it's very easy to get back into this region. This is the Roten diagram that shows the third ventricle posteriorly, the pineal gland area. And when you do it in the lateral position, you have more space in opening the two fornices. So we've already gone through these 5 layers, and this is what this looks like in the lateral position: the 2 internal cerebral veins, the 2 septum pellucidum spread, and this is the intraoperative view. We've divided and separated the septum pellucidum leaflets. We get between the 2 fornices, which are actually displaced laterally by the tumor, and you open up the tela choroidea, protect the internal cerebral veins, and find the tumor. And then this is the view at the end. You're going to see the third ventricle posteriorly, you're going to see the cerebral aqueduct, and then the pineal gland posteriorly. So we'll do this again in the lateral position: horizontal linear coronal incision, a craniotomy that extends across the midline to retract the superior sagittal sinus with the dural reflection. This opens up the interhemispheric fissure, and you'll see, again, very easy to open up the arachnoid. Look how easy it separates with gravity assistance. Gentle spreading of the arachnoid. You can use spreading, sharp dissection with scissors, come right down on the pericallosal arteries, spread the arachnoid, and spread the 2 arteries gently to expose the corpus callosum. We're making this narrow corridor much bigger for safe access. So here's the corpus callosum. There's the pericallosal arteries. We'll use image guidance to confirm our trajectory and the location. We want to make sure our callosotomy is going to be aimed posteriorly towards the posterior third ventricle. And once we make our callosotomy, we can spread the white fibers. And you're going to look for the clear membrane. Whenever you see a grayish colored clear membrane, that's the sign of ependema. So that ependema can be overlying the third ventricle. So now we've entered the lateral ventricular system, CSF being drained. And then now we're opening up the two leaflets, getting the interforniceal exposure. There's the telechoroidea. There's the septum pellucidum. So I'm going to use these little bicol spacers. This will hold my interforniceal exposure open. There's the membrane of the telechoroidea housing the internal cerebral veins. And you can see when you open up the inferior membrane, we're now going to drop into the true third ventricle here. So we'll divide the telechoroidea. And then there's the tumor. There's the tumor in the posterior third ventricle. That's the papillary tumor of the pineal region. We'll start by coagulating it and then separating it from the leaflets of the septum. And then we can come across the anterior pole of the tumor. Put another bicol spacer there to keep our space open. Continue to spread, and then we'll start to debulk the tumor here. The tumor is very soft, quite suckable, removing it in a piecemeal fashion. You can see as we introduce the instruments in and out of this interforniceal window, we're being very careful not to disrupt the fornices. It's basically a no-touch policy as we enter this interforniceal interseptal window. You're actually protected by the leaflets of the septum pellucidum. Notice how the fornices are displaced way laterally, but we're really working interseptally if we really think about this anatomically. And then this is the posterior margin of the tumor. We're rolling it away from the pineal recess, and you're going to see there's an arachnoid that's going to cover that pineal recess, and there's going to be some remaining feeders coming off of the medial posterior choroidal arteries that we have to carefully coagulate and divide. And here's the last portion of it posteriorly, rolling the tumor from the pineal recess, cutting the last vascular attachments. You can debulk this also with an ultrasonic aspirator. And then coming around the last portion here, there's the arachnoid membrane over the pineal recess region. We have to carefully separate. So it's important to use very fine micro instruments. I like this fine microbayoneted forceps, which is a great tissue separator to define those planes, and to use spreading technique to separate adherent tissue. There's the cerebral aqueduct. You can now see the cerebral aqueduct. And then using a gentle suction sweeping technique, getting this last remaining attachment, and then protecting the floor with a little micro patty. And then here's the last portion of the tumor removal. We'll then irrigate the resection cavity, and then we'll inspect. You can see the leaflets are intact. Both bodies of the fornix are intact. And this was a nice complete removal of this papillary tumor of the pineal region. Postoperative course, no memory loss, hydrocephalus resolved with no shunt. Patient was discharged to home. This is another posterior third ventricular lesion. This is a cystic lesion presented with hydrocephalus. She got an EVD to decompress the ventricles, and we opted for an anterior interhemispheric transcallosal approach. Look at the trajectory. Most of this is in the posterior third ventricle, which is easier to reach as opposed to a posterior approach, in my opinion. So here we are opening the arachnoid. Again, you've seen this many times. Spreading the interhemispheric fissure. Finding the corpus callosum after spreading the pericallosal arteries. Again, we're going to drop into one of the ventricles here. This appears to be the top ventricle because you can see the septum pellucidum here. So what we're going to do is we're going to get beyond the septum pellucidum, find the other ventricle on the dependent side, because you want control of the septum pellucidum. You want to be able to visualize both ventricles, both fornices, so you know where the septum is. You can follow the septum. You can resect a portion of it so it's not flopping in your way. And then you can leave a stump and use that as a guide to start separating the septum leaflets to find that interforniceal window. This is probably the most challenging portion of this surgery. You have to stay in the midline, but look how as we're spreading we can see that clear membrane. That is the beginning of the interforniceal corridor. That is the telechoroidea. And then we can find the telechoroidea. There's the internal cerebral vein. We're going to put some bical collagen sponges as spacers. And there is the pineal region cyst. We can put a retractor on the falx on the top side to widen this window of the interhemispheric corridor. And there's the cyst. We can see the cyst in the posterior third ventricle. Those are the internal cerebral veins posteriorly. Whoops, sorry about that. There's the ventricular, there's the cyst being decompressed. And once we decompress the cyst, we can start coming around the cyst wall. And you can see once it's collapsed, it's a little bit more difficult to separate. You've lost the turgor, but you can still work around it using two-handed technique, gentle spreading, using sharp dissection with micro scissors. And then this is the area of the cyst where it's attached to the tegmentum of the mesencephalon. This is the habenula at the mesencephalon, and we're peeling this off of the tegmentum of the midbrain. There's the posterior commissure just above the cerebral aqueduct. And then once we separate that from the neural tissue, we can separate it from the pineal recess. You can see all those small choroidal perforators, the arachnoid membrane over the pineal recess. You can see the calcium where the pineal gland is situated. And then usually there's a posterior arterial feeder here. You can see there it is. And it's a little bit attached to the pineal calcifications. And then after gently coagulating it, we can now deliver this cyst. Here is the posterior pineal lesion being removed. And then here's the final view. Beautiful view of the cerebral aqueduct, posterior commissure and pineal recess. These are the two leaflets of the septum. Look at the fornix, totally intact. Choroid, totally intact. Again, no touch policy. Very gentle micro movements. And foramen of Monroe, wide open. And here's the last view. There's the foramen of Monroe. There's the ventricular catheter anteriorly. And we'll recharge the CSF by filling the cisterns and the ventricles with saline. I generally use a gel foam bridge to bridge the callosotomy gap. Be careful not to let it fall into the ventricle, but I use it to prevent any effusion, subdural effusion postoperatively. And you can see 3 months post-op, no shunt, complete removal. She did quite well. Here's another example of a posterior third ventricular tumor. This was an ependymoma this patient had. This is another example. This was a tumor in the cerebral aqueduct. Look at the lesion here filling the cerebral aqueduct. It was growing after an ETV, but no diagnosis. The biopsy was never done. And so we went ahead and resected this. This was a rosette-forming glioneuronal tumor, very rare, unusual tumor. We got a near total debulking, left a small remnant attached to the cerebral aqueduct, and he's been neurologically intact with excellent outcomes. So our outcomes are as such. We treated mostly cholecysts, but a variety of different tumors. Most of the tumors were anterior third ventricle, and about 5 were posterior third ventricle, and we achieved gross total resection in 10 cases and 99 near total in 1 case. We had 2 recurrences, which were astrocytomas. And in terms of postoperative morbidity, we had 1 patient with transient SMA syndrome, 1 patient with persistent short-term memory loss, 1 patient who was panhypopit with a pulmonary embolus, but there were no postoperative morbidities in the colloid cyst group. So in terms of modified Rankin scale, our overall modified Rankin 0 to 1 with no significant disabilities was 93%. Memory loss was only 6.3% as opposed to 36% reported in the literature. And in conclusion, the interfornicile approach, I think, can be safely utilized applying these techniques and nuances in the lateral position, careful meticulous dissection of the interfornicile plane. And with that, I thank you for your attention.
Thanks a lot, Professor Leo, for the excellent presentation. Is there any question from panelists?
There's one question there, Sam. Do you see it in the chat?
Oh, okay. The question in chat box about how usually to perform ventricular closure. Is there any kind of device, gel foam, or something like this? Ventricular closure.
I think the question was about the callosotomy closure. Is that right? No, I just put little pieces of gel foam to prevent subdural fluid effusion. But other than that, nothing fancy.
Okay. Is there any other question? Thank you, Professor, for the excellent presentation and for joining us today. And now we will shift to next speaker, Professor Theo. Please start sharing your screen. Thank you, Leo.
Well, thank you very much, Sam. I'm just making sure, can someone check that you can hear me?
Yes, it's okay.
Okay, well, and can you tell me how many minutes I have?
We have 30 minutes.
30 minutes, okay. Well, it's unfortunately a longer talk than that. So if you don't mind giving me a warning at 25 minutes, and I can...
It's okay, it's okay, we have time.
Okay, great. Well, it's lovely to be on Neurosurgical TV again. John, good to see you.
It's okay, you have time.
Great, thank you. Good to see you, and it's always a hard act to follow with James. That beautiful surgical technique that I was watching and you were witnessing. I'm going to take a different approach to the ventricles. Firstly, I like to make sure that you understand that there are true interventricular tumors and there are periventricular lesions, and they're 2 different animals. One is you very rarely use pure endoscopy. They're quite vascular. They're often gliomas and the more malignant variety. But they still don't require a large craniotomy. The purely intraventricular lesions, they can be addressed purely endoscopically. They're often relatively avascular, and it's completely different animal, different pathology. They're often low-grade gliomas like Seeger's, central neurocytomas, colloid cysts, again, they very rarely require large craniotomy, given that they are deep to the surface. So let's talk about different approaches to different ventricles. First, we'll go to the lateral ventricle, talk about periventricular lesions. The transcortical approach is probably the most common approach to periventricular lesions of the lateral ventricle. And I'm talking about either transsulcal or transgyral approach to these lesions. And here's a few examples of lesions that are, not really in the ventricle, but certainly involving the ventricle. They're very deep to the surface. And this is what I would describe as a periventricular lesion. Again, this pathology is mostly more malignant than the other variety. The transcortical approach is excellent. Of course, you've got to try and pick the least eloquent part of the brain to go through. Those of you who've recently heard my talk on connectomics, I think you understand now that I used to talk about going through non-eloquent brain. I now have changed that narrative to going through eloquent brain, but the least amount of eloquent brain. There are many different ways to try and ascertain the least eloquent part of the brain. The technique I use is using preoperative maps. I use the QuickTone map made by Omniscient because it's very comprehensive, and it shows you not only where the motor fibers are and the motor parcellations, but also the higher order networks like central executive network, DMN, and salience. And I think it's really imperative that you try and pick the least eloquent part of the brain to go through. It's a small incision, obviously, because the lesion's deep, a small craniotomy. And again, one can go through the frontal lobe, the parietal lobe, or the temporal lobe. And here's some more examples of those periventricular lesions. I think you can see that they're more malignant, and that's the sort of approach. They're the angles that you can get with a small craniotomy. It's always, again, please remember the basic tenets of surgical approach to these lesions, and that is the 2-point rule. Always try and ascertain the deepest point, most superficial point, draw a line to the surface, and make sure that line avoids some of those things like the optic radiation and those other pathways like IFOF and all those cortical parcellations. Once again, the craniotomy is a small craniotomy. It's a keyhole craniotomy. Why? Because, again, when you're deep to the surface, you do not require a large craniotomy to get to these lesions. So the craniotomy is about 1.5 centimeters in diameter. It's really no bigger than a big burr hole, and therefore a straight incision. The transparietal lobular approach is a well-documented approach. It's an excellent approach to the posterior part or the trigonal part of the lateral ventricle. And again, here's a lesion involving the lateral ventricle, the trigone going down into the temporal pole. The transparietal approach is the best approach here when we worked the 2-point rule. A point at the lowermost point, its most superficial point. Here's a beautiful sulcus, and that's the trajectory that I chose to take out this lesion. In other words, the long axis of the tumor. Then again, one of the other principles is to position the patient so you don't require self-retaining retractors. That's only going to clutter the space. And when you look at me operating here, you'll see that, in fact, I use a natural movement of the brain to get to that lesion. Oh, sorry. I can show you that video later when we have time. But when you watch me operate, you'll see that any sort of fixed retraction in that cortical incision, like a tubular retractor or a fixed retractor, all it's going to do is be an impediment to your angles of view that you require to take out that tumor aggressively. The transoccipital approach is a reasonable approach if they've already got a visual field defect. It's very difficult to avoid these optic radiation fibers. Now, sure, the lower you go, the more chance you've got of avoiding them. But even when you go low, you often affect some of those fibers. And if you don't affect them, then you're going to affect IFOF. So the transoccipital approach, reasonable if they've already destroyed all these fibers and they've already have a visual field defect. But if they don't have a preoperative visual field defect, then you should choose another approach. The other approach I like using is the infratentorial supracellular approach, because you're not going through those fibers. Again, if they're not destroyed, this is what you're doing. You're coming from below, not from the side. Again, it's a keyhole approach, small craniotomy, straight incision, big opening in the tent. So don't feel that you have to do a small opening in the tent. I've read in the books that theoretical risk of herniation of the occipital lobe into the posterior fossa. It doesn't happen. So please don't worry about making that tentorial opening as large as you like. Here's the sort of approach. Infratentorial, supracerebellar to avoid the lateral fibers, which are often optic radiation, which then cause a postoperative visual field defect, which is not good in terms of driving and independence. So to avoid coming laterally, to avoid those fibers, it's an inferior approach through very, very low eloquent brain here, underneath here. And you can see that you're only going through about 1 millimeter of tissue here anyway. So that's the approach. Infratentorial, supracerebellar, no fixed retraction, small craniotomy, large opening in the tent to achieve a resection of this lesion without damaging the lateral structures. Here's a smaller lesion if you want to try a smaller one first, and you'll see that again, it's right in the trigone of the lateral ventricle. So this is a good approach for periventricular lesions of the trigone. And there's the approach again, craniotomy below the tent, wide opening, and a very easy approach through very low eloquent brain in the mesial part of the occipital lobe or the trigone of the lateral ventricle. There's another one, and another one, and a big intraventricular lesion. This is a meningioma, well, smaller falcotentorial meningioma, but again, it's in exactly the same location as an intraventricular meningioma of the trigone. Okay, let's talk about the transcallosal approach to the lateral ventricles. James did a beautiful talk just before me, showing the lovely dissections, interhemispheric, transcallosal, and here going interfornicale. I personally don't like the interfornicale approach. I think it runs the risk of damaging both fornices, and I prefer a subfornicale or subchoroidal approach to third ventricular lesions, which we'll talk about later. But firstly, let's talk about the approach to the lateral ventricle. Again, transcortical for these midline or very paramedian type lesions that don't extend laterally is a beautiful approach. So remember, interhemispheric, transcallosal, transventricular for paramedian or very central midline type lesions in the periventricular region. This is extending out laterally. So what do? We come from the contralateral side. So this is a contralateral approach to a periventricular lesion of the body extending more laterally than those other two lesions I showed you. Furthermore, we can also take out this multifocal part of this GBM. There's the long axis rule or the trajectory rule. And again, we're going from the contralateral side because of the lateral extension of this periventricular lesion. Here's another one. Ipsilateral doesn't do it, contralateral does it. Even with the contralateral approach, this is so lateral that we do need the endoscope to get us out there. I'm not going to go through this video again. James did a beautiful job. Interhemispheric between the pericallosals. And remember, when you get into the ventricle, it's easy to skive off to the contralateral ventricle because you're aiming that direction. So you've got to make it very sure that you're doing an ipsilateral approach to the ipsilateral ventricle. And James showed that beautifully. I don't like these incisions. This is what I was taught, one of these incisions. It simply devascularizes and desensitizes this scalp here. You're cutting through a lot of nerves that are coming backwards. So I go for the paramedian incision, which gives a much better result in terms of damaging those nerves, the supraorbital nerves and supratrochlear nerves. Okay, what is this one? This is a pure interventricular. Sorry, let's get back to the topic again. This is pure interventricular lesions. Remember, I told you these are different beasts. They're often less vascular, more benign, well circumscribed, and I think it's reasonable to think of these as a purely endoscopic approach. So it's a transcortical approach to purely intraventricular lesions of low vascularity. And here's the perfect example. Low vascularity, well circumscribed, nicely defined. And this is how I do them, with a very keyhole type approach, using a purely endoscopic technique. That's the choroid plexus. This is the lesion. And we use all sorts of different tools, you know, whatever tool you like. But I use a sucker, a bipolar, a monopolar, and a grabbing forceps to take out these very low vascular, or often avascular, low-grade lesions. There is one little secret here, and that is try and take a more, a longer approach. If you take a very short approach to these, you come down directly onto the tumor, and it's quite disorientating. If you enter the ventricle distant to the lesion, it gives you more working space, better angles, and it helps you define the borders of the lesion better than coming directly onto it. And here's a little sort of cartoon demonstrating that. Okay, if we have a lesion right there, that's the more direct approach. That's the more indirect approach, but you can see that the working angles are better because it's a longer approach, it's deeper down, and you're going through a ventricle so you can get a better look at it. Coming down on the lesion can often disorientate you because you're facing the lesion directly and you can't see all the borders of it. So I know it's a little bit counterintuitive, but I would suggest for purely interventricular lesions done purely endoscopically, transcortical, a longer approach through the ventricle gives a better orientation to the lesion. Some of the little pearls and precautions. A lot of people say, what if you get a lot of bleeding with a purely interventricular approach? There are many different techniques to stop bleeding, like tamponade with the scope itself, monopolar, but a technique that is often not talked about is just emptying the ventricle. If you empty the ventricle of CSF, and you don't do that by sucking out CSF, that just collapses the brain. You do it by injecting air. So you get an empty syringe, you inject air, you create these big bubbles, and that does help you tolerate and manage intraventricular bleeding a whole lot better than trying to swim around in cloudy CSF. Here's a purely intraventricular meningioma. Remember, these are very treacherous. Why? Because they get their blood supply from the mesial border, and you often approach these from a lateral approach. So the vascular supply is at the end of the case. This is one case that I'd probably do now. I was going to say that, you know, coming from below does get you medial access early, but this is a large lesion, and the long axis again is in the lateral direction. So I actually would do a transcortical approach to this, but understanding that that the vascularity is the last thing you're going to see, and therefore it's a very difficult case and a very dangerous case if you don't appreciate that. Small incision again. Why? Because it's deep. A small craniotomy. So there is very much a keyhole approach through the least eloquent brain you can get. Thankfully, I can remember this chap. He had a visual field defect before surgery, had a visual field defect after surgery, but no other problems. The transcallosal approach to interventricular lesions of the lateral ventricle. Again, these are for bigger lesions or for multiple lesions. This patient had many intraventricular ependymomas. You can see them all here. I like the transcallosal, transventricular, transcallosal approach to these because you can get access to both lateral ventricles, both frontal horns, both occipital horns. You don't get good access to both temporal horns, but again, you can approach them separately. But this gives you really good approach to multiple lesions in both ventricles. And again, look what I've done. I've taken out CSF, not sucked it out. I've injected air so that now I'm operating in air to try and reduce the amount of bleeding. Let's go to the third ventricle now. Again, we can divide that into anterior, middle, and posterior. Why? Because there are different approaches to each part of the ventricle. Anterior approach here, such as colloid cysts, middle, and posterior. They're mostly endoscopic approaches. You can do anterior third ventricle through a transphenoidal approach if it's breached the floor. You can go from a translaminar approach if it's supraoptic, suprachiasmatic. Transforaminal approach if the frame of Monroe has been expanded naturally by the tumor or by hydrocephalus. James showed beautifully the interfornical approach, but you can also use the subfornical or subchoroidal approach to the third ventricle. And then again, remember I talked about the transtentorial approaches, either infratentorial or supratentorial to the posterior third ventricle. So let's give you some examples. This is a recurrent craniopharyngioma that has clearly breached the floor of the third ventricle. It arose from below it. So perfect for a transphenoidal approach, because look at the long axis, beautiful resection, lovely anatomy at the end, and again, a good outcome. This is right in the anterior third ventricle. It turned out to be a low-grade astrocytoma. It's just behind the A1A2 complex. So a transfrontal, translaminar approach to this lesion is just perfect. Eyebrow approach, complete resection, and again, a good outcome, and cosmetically a good outcome as well. In this patient, we understood that the foramen of Monro was expanded, so an interhemispheric, transcallosal, transventricular, transforaminal approach coming from well behind the coronal suture, so you have the right approach to this very anterior low-grade glioma. Complete resection, good outcome. Here's another one. We needed endoscopic assistance for this because it extended out laterally into these lateral recesses. Remember, the interhemispheric transcallosal approach gives you good access to very midline or just paramedian lesions. It really doesn't give you good access out laterally, where you need endoscopic assisted surgery to get out the lateral portions. This patient had a previous biopsy with a large incision. You just don't need that. Remember, it's deep to the surface, straight incision. And again, how do you work out where you're going to make your craniotomy? You look at the 2-point rule. This goes very posterior. So here's the coronal suture. It's easily all behind the coronal suture. Quite a long incision because we can't sacrifice veins. And so we're going to have to use the space either in front of or behind the veins when we do this approach. Colloid cysts, I do a lot of these, most of them purely endoscopic, but sometimes they're large. I do an interhemispheric transcallosal approach because it's just quicker to do that than with the endoscope. When I use the endoscope, again, it's a transcortical approach, very lateral approach. Yes. 25 minutes? Okay, good. Right, yeah, sorry, there's another 10 minutes. I'll be, sorry?
Take your time. Take your time.
Oh, okay. Thank you. Thank you. Okay, so most colloid cysts I do purely endoscopic. It's a very lateral approach. So you've got to make sure you don't damage the head of the caudate when you're coming in laterally. 7 centimeters is a bit of a long reach. I try and do 7 centimeters, but I mostly go about 5.5, 6 centimeters. So it's transcortical, transventricular, push the head of the caudate down to get to the colloid cyst. If you use your frameless stereotactic guidance to take you directly to the colloid cyst, you'll go through the caudate head, and you don't want to do that. If it's purely midline, stuck right up in the roof, then yes, I think an interforniceal approach is reasonable. Although, like I say, I'll stick by my first statement, and that is I don't usually like the interforniceal approach because it does jeopardize and risk damaging both fornices. That was an intraventricular craniopharyngioma. This was a JPA. This is a interhemispheric, transcallosal, transchoroidal or subchoroidal approach to this big lesion. You can see the corpus callosotomy. And again, why could I do it through that? Because it was all very midline. Just be careful when you do the transchoroidal or subforniceal approach. A lot of people say, well, how do you choose whether you go above or below the fornix, above or below the choroid plexus? A lot of it is determined by the patient's individual anatomy. What I do is I often try and go subchoroidal first. I look for the nice dissection plane. And if I get that nice dissection plane, that's the preferred approach. Here's the fornix, here's the choroid plexus. Again, subchoroidal, or some people call it a transchoroidal approach to the third ventricle. There's a large neurocytoma. Beware the fornices. Remember the anatomy of the fornices. They're close together. Just look at the anatomy. It gets closer and closer to the septum pellucidum. So sure, you're going to have septum pellucidum anteriorly, but if you go posteriorly, remember the fornices are stuck or in juxtaposition to the inferior border of the corpus callosum. So when you do your corpus callosotomy, it's very easy to damage the fornices if you don't appreciate that anatomy. Also appreciate that they get closer and closer together the further you go back. So again, this interfornical approach gets even more challenging the further posterior you are. Beware the midbrain, any third ventricular lesion. I was taught, never mess with the hypothalamus. My narrative now, or my dictum now, is never mess with the midbrain. This is a young girl who had a midbrain lesion. I did a interhemispheric, transcallosal, subchoroidal, transventricular approach to the midbrain. Again, lovely approach, but when I got there, I realized that there was a bit of normal midbrain over the top of this, and I went through that normal midbrain and had a devastating outcome. Why did I get the devastating outcome? Because you don't understand how eloquent that tissue is. So if there's any tissue at all in these lesions, you do not breach this tissue. This is all midbrain, very eloquent midbrain stretched over the top of this lesion. This is a transtentorial approach, interhemispheric, through the tent behind the spleen of the corpus callosum. So it's not a transsplenial approach, it's not a transcallosal approach, it's a interhemispheric, transtentorial, retrosplenial approach to these posterior third ventricular lesions. That turned out to be a neurocytoma, postoperative day 2. And the little pearl and precaution I give you is that this is the incision I was taught and is in the textbooks. I've just modified that now to a simple midline incision. Why do I make it midline? Because sometimes you have to go both sides of the midline with bilateral craniotomies. So I think a midline approach is better than a paramedian incision. Try not to retract the occipital lobe. You can coagulate and sacrifice those occipital bridging veins with impunity. They're attaching to the vein of basal vein of Rosenthal, and the last thing you don't want to do is pull off that. So those inferior mesial occipital bridging veins, I take them before I do any damage. The endoscope is extremely important to use with this approach. Finally, the skid approach, the posterior third ventricular lesions. What's the long axis? The long axis is below the tent. And if the long axis is below the tent, that's the approach I use. I don't position them prone anymore. I now position them in a supine position with a head turn. So this is a paramedian incision, 2 finger breaths away from the midline, infratentorial, supracero approach to the posterior third ventricle. Taking these veins with impunity, no fixed retraction on the cerebellum, making sure the craniotomy goes all the way up to the lower surface, inferior surface of the sinus. And finally, approaches to the fourth ventricle. Of course, fourth ventricular lesions can be purely intraventricular or periventricular. And again, the approach is completely different. This is a periventricular fourth ventricular lesion. I did a retrosigmoid approach to this, and the endoscope, again, is a very, very valuable tool in making sure you get complete resection all in and around these cranial nerves. So we've done the microsurgical dissection of this large lesion, and now we're taking out remnants that are stuck in the foramen of Luschka that you couldn't see with a microscope, but you can see very nicely with the endoscope because it's looking around the CP angle into the Luschka foramen, into the fourth ventricle. So again, retrosig, microscopic, endoscopic assistance for those portions that are hidden by the cranial nerves and the vessels. If they're purely intraventricular, I do a suboccipital approach, a classical suboccipital approach. These are multiple recurrent ependymomas. And again, I think you'll see the value of the endoscope in taking out these lesions. It doesn't have to be a large incision. It doesn't have to be a big craniotomy. Sometimes you can even go through the occipital membrane. You don't even have to take off any bone. Just take off C1, bit of the membrane, and you get into the fourth ventricle. If you do have to take away some of the bone, you don't have to usually take a huge amount of bone because, again, it's very deep to the surface. If, of course, it's superficial to the surface, you have to take a big craniotomy. But most of these fourth ventricular lesions are contained within the fourth ventricle and can be accessed through a keyhole craniotomy. So thank you for your attention. I'd like to conclude by saying that most ventricular lesions can be safely and effectively removed through a mini craniotomy. By definition, they are deep to the surface. They do not need a large opening, and they can be done through a craniotomy about the size of your thumbnail, about 1.5 centimeters. Endoscopy is essential, whether they're periventricular, interventricular, microscopic, or purely endoscopic. The endoscope becomes a very valuable tool because of all the nooks and crannies and all the different parts of the ventricle that have to be accessed. Surgery for third ventricular tumors is high risk if it involves the underlying midbrain. And I would say that that is the riskiest of all operations if the midbrain is involved by third ventricular lesions. Thank you very much.
Thank you, Professor Teo, for this excellent presentation. I have one question for you, sir. Do you recommend to start by conventional surgery, then keyhole approaches, or to start by keyhole approaches?
There's two parts to that question. If it's intraaxial, deep to the surface, I think that a keyhole small craniotomy is probably easier and safer to do than a large craniotomy. I don't think you have to learn by doing a large craniotomy first, but you do have to learn that it does require preoperative assessment and preoperative planning. You can no longer ask your resident to go downstairs and do a big frontal craniotomy. If you want to do a small craniotomy, you've got to figure out the line of approach, the trajectory. And to figure out the trajectory, you need to know the deepest and most difficult part of the tumor to access. You put a point on that. You put a point on the most superficial part of the lesion, and then you draw a line, and that takes you to your surface approach. If that line takes you through eloquent brain, then of course you're going to have to modify your approach a little bit. And that's when the endoscope becomes a very valuable tool. So no, small craniotomy is absolutely fine to teach residents right from the get-go. Now, let's talk about skull-based surgery. Skull-based surgery is a little bit different. You're encountering many different nerves and vessels. Sometimes you're clipping aneurysms. Therefore, you need straight applicators to get in there, which means you need a big opening. I think with skull-based surgery, I would encourage my residents to do the sort of classical opening so they can learn the anatomy, they can feel very comfortable. And then with a few cases under your belt, I'm not talking a whole lifetime, I'm talking maybe 5 or 10 cases, you'll get a feeling that a lot of those classical skull-based approaches waste a lot of bone opening, and they expose a lot of brain that doesn't have to be open. If you look at the classical pterional, for example, as an approach to aneurysms of the circular filus, you expose a lot of frontal lobe, never need it because it's a pterional approach along the skull base. So overall, yeah, I think you can teach residents right from the get-go that they can do a lot of these tumors through a keyhole small craniotomy if they plan the case comprehensively and correctly before they put knife to skin.
Okay, yeah. If we are trying to fasten our learning curve, how to make it by cadaveric dissection or by courses, or how to make it
more absolutely
faster?
No, that's imperative. It's imperative to do that. You can't upskill to a keyhole approach or a keyhole philosophy without reading, changing the way you think about things, looking at the MRI scans differently, adopting new technology like the endoscope, and learning on cadavers. Absolutely, you can't go straight into it. So I think all of that is very important when you're upskilling to a different sort of technique or a different approach. It is within our grasp. It is better for the patients. Look, I know there's a lot of skull-based surgeons out there who speak very poorly of the keyhole small endoscopic approaches, but it's the goal of surgery that we should keep paramount in our minds. If you do a small craniotomy and you can't achieve the goal of surgery, you leave tumor behind, you damage the patient, you damage the brain, you tear a nerve because of the small craniotomy, then that's not a keyhole approach. That's a ridiculously small, inadequate approach. If, however, you can achieve the goals of surgery through an incision this small versus this big, why would you do a big incision? And when I'm approached at meetings and they go, it's more dangerous, it's harder for the surgeon, it's not about the cosmetic results, it's all about the brain results. That's when I say to them, look, there's not a war here. We're not disputing that. It is about safety. It's about patient safety, patient outcomes, and reducing morbidity. But this is where I get really upset. It is harder for the surgeon. It's more challenging for the surgeon. They have to upskill. They have to get out of their comfort zone. They have to learn to use the endoscope. They have to learn not to use retractors. It's more difficult for the surgeon. But are we doing the operation to make it easy for us, or are we doing the operation to make it better for the patient? It does require skills. It does require you get out of your comfort zone. It does require you to start using things like, hybrid instruments, position your patient so you don't need self-retaining retractors. All these things are very, very important if you want to start using keyhole approaches to deep-seated lesions.
So in your experience here, how many times do you change your keyhole approach to conventional?
Yeah, so we published our results of keyhole retrosig to CP ankle lesions, 890 cases. Not one single case needed to be changed to a bigger approach. I haven't published my eyebrow approach, I'm sorry, but I present it. There's 1,450 cases, all done through the eyebrow. It's the largest series in the literature. Not a single case that I have to open extend it to a larger opening. So again, it's all about planning. And if you plan correctly, then you'll be able to do it through these keyhole approaches.
So at what point sir, you have changed your plan? At what point you have changed?
Well, I had a very traditional neurosurgical education. I was taught the typical COZ, the typical terional, the question mark incision, the bifrontal, the lazy S-C-shaped sig. I was taught all of them. And so I use them, but even as a resident, I used to think, hang on, why did we do such a big incision, big craniotomy when we only used a tiny amount? So I think I was inquisitive right from the start. I worked with Sam Al-Mefti when I was in Little Rock, Arkansas, and he really didn't like the eyebrow approach and sort of told me not to use it. So when I was with him, I didn't use the eyebrow approach. But when I left Little Rock, Arkansas, I started using the eyebrow approach, and I've never looked back. So here's the advice I give people. If you find it all a bit too confronting and a little bit too challenging, this is what I ask you to do. Every time you do a traditional big approach to a tumor, assess the operation at the end to see if you could have done it through a smaller opening. And if you could have done it through a smaller opening, make your next case a little bit smaller. Then assess again. If it could have been done smaller, make it smaller. Sure, one day you might go, oh, I can do it smaller and get down to this tiny, ridiculous incision and think, oh my God, I've gone too small. But that's not such a bad thing to learn from your mistakes. But I'm suggesting to you that you gradually reassess your approach to tumors and understand that it does matter. Because when you say to these surgeons, those surgeons who go, it doesn't matter the size of the incision. It doesn't matter about the size of the craniotomy. What matters is the way you treat the brain. My question then is to them, okay, so you just did the operation through an incision this long and a craniotomy this big. Why didn't you do it through an incision this big and a craniotomy this big? Why didn't you double the size of your incision and double your craniotomy? They look at me complex and go, why would I do that? I did it through that. And that's exactly my point. Why would I make an incision that big when I can do the operation through an incision that big? That's the point. So it does matter. It does matter. It matters in terms of cosmesis, operative time, blood loss, destruction of nerves and arteries, collateral damage, damage to the brain that's been exposed. It doesn't have to be exposed. You know, it does matter. And we've shown that. We've shown that if you do a keyhole approach, patients recover more quickly, less need for narcotics post-operatively, less need for a prolonged stay in hospital, better cosmetic outcomes. So, you know, it does matter to patients, and it's better for the surgeon as well. Okay, so sorry,
Thanks
you
a lot,
froze up
Professor
there.
Teo, for this excellent presentation. Thanks a lot, Professor Teo, for excellent presentation and discussion.
Okay, pleasure. Thank you very much.
Thank you, sir. And now we will shift to next speaker, Professor Matthias. Please start sharing your screen. Unmute yourself, Matthias.
Can you hear me?
Yes.
Hi, Sean. Hi, Smed. Thank you very much for your invitation. It's a huge pleasure to me to be sharing this this webinar with so well-recognized neurosurgeons. I was really attentive listening to Professor Charlie Teo. From me and so many young neurosurgeons have learned from his publication and his books. And thank you very much for your message and for push forward the level of the neurosurgery around the world. Thank you very much. And congratulations again, Samet, for this initiative to join so many friends from the world in this webinar, touching some interesting topics around the neurosurgery. Okay, the topic that I have to talk now is the surgical strategies for central neurocytoma resections. As as we know, the central neurocytoma classically were defined as rare and benign lesions of the central nervous system. Nowadays, we know that not all the central neurocytomas are benign lesions, because a small proportion of central neurocytomas could present in the histological findings, necrosis, and key 67 elevated more than 2%, and some of the central neurocytoma are atypically under and the growing the velocity could be faster than the regular central neurocytomas. The first description of the central neurocytoma was described in 1982 by Hasson et al., and they established this entity. From this date to nowadays, more than 600 of cases were reported in the neurosurgical literature. You know that we know that there are supratentorial ventricular tumor located, and especially in young adults patients, and it have not predilection between man and woman. Generally considered to be benign tumors, but we know that it is not so. It is not true in all the cases. And the WHO classification is grade 2, and of course, some cases have pure clinical outcome. The cases that have pure clinical outcome are the cases who present MIB1 hymonostochiometry or key 57 greater than 2% in the histological findings. There are a new concept around, especially between the histopathological community, about to name atypical central neurocytoma to those tumors with atypical histological, with necrosis and some histological findings that have an increased risk of poor outcome, instead resecting the total tumor during the surgery. And the recommendation is to follow closely this patient, because some of them could present growing of the tumor 5 or 10 years after the surgery. An interesting publication 20 years ago is this paper that this group compared between 310 patients from 19 different institutions operated on, and they divided the patient with complete tumor resection alone, complete tumoral resection plus radiotherapy, incomplete tumoral resection plus radiotherapy, and only incomplete tumoral resection with the microsurgery, independent with the microscope or the endoscope as the surgical tools. And they found that the series with complete total resection were the patients that have better follow-up after 10 years of the follow-up. And this is why one of the main recommendations for the neurosurgeon who have to operate patients with central neurocytomas is to try to resect the total tumor lesion in order to provide to our patients the better outcome in the long follow-up. This is a case, in order to highlight the topic of my lecture, this is a case of a young woman, 27 years old woman, who suffered a car accident, and then she in the CT scan, in order to check how was his brain after the car crash, the center who made the CT scan found a big lesion located in the body and part in the frontal horn and part in the atrium, a big lesion located in the lateral ventricle, in the left lateral ventricle. In the MRI, we can observe a lesion in contact with the septum pellucidum, and an ovoid lesion, and in contact with the caudal nucleus, and in contact with, in part, with the thalamus. As we can observe here in the coronal cuts, this the lesion is really close to the thalamus here, and this is why this kind of tumor are really a challenge to resect totally, because in some point the central neurocytomas are in close contact with the normal brain tissue, and as being tumors located inside of the lateral ventricle, sometimes we need to separate the surface of the tumor from the surface of the thalamus of the the caudal nucleus, as in the case that I want to show here. Here we can observe in the inferior border of the tumor the internal cerebral veins, and of course the thalamus striatus vein in the inferior border here. In the sagittal projection, we can observe the tumor really close to the corpus callosum, as here we can observe, and of course the thalamus is located in the inferior part of the tumor. These tumors, as our previous speaker said, these tumors are really vascularized tumors, and the resection of that tumor are really complex, because the bleeding of the tumor during the resection sometimes turns the surgery a little uncomfortable until you finish the resection of the total tumor lesion. Here it's the anatomy well explained by Eduardo and Kangi and Murlu, but it's important to remember the structure that we have for resect this kind of tumor. First of all, it's important to remember that the pericallosal artery is in close contact with the corpus callosum. Sometimes the regular callosotomy should be performed not so anteriorly as we want, and we need to perform a posterior callosotomy or a medial callosotomy in order to access directly to the tumors. Here we can observe the thalamus, the foramen of Monroe, of course, and the internal cerebral veins behind of that region. Here is we can observe the corpus callosum, the transverse fibers of the corpus callosum that we need to transect in order to gain access to the lateral ventricle in this case. This is a left lateral ventricle. These tumors were adherent to the head of the caudal nucleus, the tail of the body of the caudal nucleus, and of course to the superior surface or the ventricular surface of the thalamus itself. Of course, that the resection of these tumors are really a challenge when we need to operate this patient. Taking in account that the main objective is to resect the totality of the tumor. One of the difficulties when we need to operate this tumor is that the color of the tumor are gray or brownish tumors, similar to the normal color of the corpus of the thalamus and of the caudal nucleus. This is really a difficulty when we need to separate the tumoral surface to the normal tissue surface of the medial central core inside of the lateral ventricle. Here we can observe this is the anterior, this is posterior, here is the foramen of Monroe, here is the superior surface of the thalamus, the fornix, of course, the plexus choroideus, and here we can observe the head, body, and tail of the caudal nucleus. This surface are the caudal surface that we need to separate to the tumor in order to resect the totality of the tumor. It is very important when we navigate endoscopically or microscopically inside of the lateral ventricle to taking care to these veins, the thalamus straight vein and the anterior septal vein, but more important is the thalamus straight vein, in order to preserve it for having a good outcome after the surgery. Here is a coronal projection of the anatomical structures, and we can observe here a beautiful blue sheet, blue coloration of the brain. We can observe in blue the gray structures of the brain, and the tumor sometimes is adherent to the inferior surface of the corpus callosum and to the caudal nucleus, as we can observe here, and it sometimes is adherent to the surface of the thalamus, and this turn really challenge the complete removal of this tumor. The surgical tools that we use for the resection of this kind of very vascularized tumors located in the lateral ventricle are this spatula aspiration system that we have created especially for this surgery and another surgery like schwannomas or another surgeries. We use a 0 grade, a 30 grade, and 70 degrees grades the endoscope. We use it, and this is a beautiful tool, a very useful tool. This is a micro mirror from 5 millimeters, 7 millimeters, 8 millimeters, and 12 millimeters that we use in order to check the spaces that it is impossible to access with the microscope or with the endoscope, in order to check the total removal in the blind spot places in the surgical scenario. This patient was operated performing an RC-form incision in the skin. We perform interhemispheric craniotomy. This is the sagittal sinus. We perform a craniotomy centered in the sagittal suture, in the sagittal sinus. And here is the video where we can observe that retracting the hemisphere in the left, we can observe here the corpus callosum. We use a rounded cotton in anterior and in the posterior segment in order to maintain the interhemispheric fissure separated during the surgery. And this is a tumor that presents a lot of bleeding. The tumor bleeds until the end of the resection. We can observe here that the color of the tumor is really brownish, and it's difficult to understand the anatomy of the tumor and differentiate it to the normal structure. This is the micromirror that we use to inspect the end of the cavity. We have here a small portion of the tumor that was resected in order to complete this resection of our patient. These are the steps: anterior callosotomy. The callosotomy was performed more posteriorly to the regular anterior callosotomy. The tumor in a gray color, and the final cavity at the end of the surgery. The patient evolved favorably. This patient was operated 3 years ago, and we can observe here the histological findings that are characteristic. We found rounded cells, and it is important to differentiate between those benign and malignant central neurocytomas, because the malignant, the cellular are not regular when we compare the shape between one and other. And this was a regular central neurocytoma. We can observe here the shape of the cells are equal between one and other. In some cases, we can observe necrosis. Yes, these are tumors that we need to be follow up more closely. And in this case, we can observe that the shape of the cell are really different, with irregular shapes in the borders. And here we can observe synaptocene immunoreactivity and MIB1 immunohistochemistry more than 2% in these histological studies. This is the postoperative MRI, and the patient had 3 years in the follow-up after the surgery without any recurrence and going well. The patient did not receive radiotherapy plus the total resection of the tumor, and we performed in this patient 1 MRI yearly. This is another case that I want to show you. This is a 22 woman with headaches and diplopia with this huge tumor that was suspected to be a central neurocytoma. And we decided to operate this patient. This patient was operated 1 year ago with a good follow-up and a total resection of the tumor. We can observe here that the tumor is in close contact with the superior surface of the thalamus, inferiorly, and superiorly is adherent to the corpus callosum. We performed this surgery exactly like the previous one. We access it through a right interhemispheric approach. First of all, we need to find the 2 pericallosal arteries in order to protect them with small cotton. It is very important to avoid the lesions of these arteries. We start to the anterior callosotomy, and we can observe cerebrospinal fluid emerging through this hole, and the tumor with the similar color that the previous case. This is a gray tumor or a brownish tumor that we need to coagulate, separate piece by piece using microforceps, using for the superior surface of the tumor, the ultrasonic aspiration. And this is the final view of the surgery, and we check all the cavity and the inferior surface of the corpus callosum using these micro mirrors at the end of the surgery. This is the step by step. Here the interhemispheric approach, the location of both anterior pericallosal arteries, the callosotomy, and we can observe here the brownish color of the tumor. I want to say again, it is a complex tumor because we need to operate through a small hole in the corpus callosum. It is a very vascularized tumor, and we need to resect small pieces and coagulate, resect small pieces and coagulate, and going forward through to the end of the resection of the tumor. Here we can observe the right thalamus straight vein that was located in the deeper portion of this central neurocytoma. And of course, here is the thalamus straight vein. This is anterior septal vein, and it's very important to preserve this vein in order to have good outcome with our patient. The final cavity checked with the micromirrors and the endoscope. And thank you very much again for your invitation and for being me part of this amazing webinar, Samis.
Thanks a lot, Professor Matthias, for this excellent presentation. Is there any question from panelists? Okay, Matthias, my question, you are talking about the tumor as so bleeding. So how you control the bleeding in this tumor?
I try to divide the tumor because it is impossible to expose the total surface of the tumor without producing damage in the corpus callosum, and of course in the two medial surfaces of the brain. And we try to make a hole inside of the tumor and coagulate and try to debulk the tumor to be in access to the lateral surface. I think that if you divide the tumor, coagulating the bleeding points inside of this debulking is a good option. But anyway, I think that this kind of tumor with the high vascularization are really a challenge. More of thinking that we are working in a small hole, through a small hole in corpus callosum and inside of the lateral ventricle.
So what is the most serious complications that you have faced with these cases? And what do you think the most appropriate way to avoid it?
I have operated only 4 central neurocytomas, and all the patients recovered after surgery without any important complication. One of the patients, the first patient, suffered during at least 6 months a disconnection between the right and left hemisphere because we needed to perform and the callosotomy posteriorly to the suggested area in the anterior segment. But the patient went to the neuropsychologist during 6 months and he recovered perfect now, but he suffered disconnection syndrome with anosognosia, prosopagnosis, yeah.
You didn't face any complication from damaging of arteries or veins?
No, in our cases, we have not any major complications. Only this minor complication that the patient recovered, but it is important to preserve the bridged veins at least as possible. The second part, when we reach the deep surface of the interhemispheric fissure, we try to identify the 2 pericallosal arteries and to hide them between both of them between small cottons in order to prevent the damage of these arteries during the resection process, and in order to avoid the vasospasm during the manipulation of these arteries. Yeah. It is. I think that this is important, and of course, when we need to work in the deepest portion of the central neurocytoma, I think that this is the most difficult point of the tumor if it is adherent to the thalamus, because the properly delimitation of the thalamus surface and the end of the tumor is not so clear, and in this sector, sometimes we have the thalamus straight vein or some important veins that we need to preserve. At this point, it's really complex due to the tumoral characteristics.
So you start from the center of the tumor or trying to reach the anterior border or posterior border first?
So, sorry, Samet, I don't understand the question.
You start your operation from center of this tumor, or you are trying to reach the anterior border or posterior border first?
Good question. Good question. As everybody knows, to treat a tumor, the ideal way to treat a tumor is to work in the surface of the tumor, and it's applied for meningiomas, for schwannomas, and for tumors that are easy to reach or are located in the cisternal or in the convexity. But working in a 2 centimeters callosotomy with these huge tumors that the tumor can be from 4, 5, or 6 centimeters, it's really difficult to reach all the surfaces of the tumor properly. Without producing any damage in the normal brain tissue. This is why we prefer to work inside of the tumor, going in a different direction of the general rules, in order to divide the tumor, coagulate quickly the center of the tumor, and try to collapse the lateral walls, the anterior, posterior, and lateral walls to the center, and resect in the center the tumor. This have a problem that the patient have an important bleeding during the surgery, but at least in our team we didn't find another way to work, exposing the complete surfaces of the tumor without produce a huge damage in the deep portion of the interhemispheric fissure.
Okay, Professor Musa asking about post-operative residual. If you have some small tumor, do you go for surgery or just follow-up?
Oh, this is an interesting question. Thinking that this could be called as a benign tumor, and if you resect the tumor completely, you can give it to the patient the cure. For small tumors, we can observe and controlling with MRI between 6 months with each other. But anyway, we need to know where is the tumor located. If the tumor is close to the foramen of Monroe, it could be a problem without reaching a huge volume. But anyway, for small tumors like benign tumors, if there are small tumors we can observe, like a subependymoma. Sorry.
Okay, thank you, Professor Matthias, for excellent presentation and discussion.
Thank you very much.
I think we have reached the end of this webinar. If you have more words to say, John.
Yeah, thanks everyone for coming, and thanks for putting it together, Sam, and thanks Matthias and all the speakers. And we look forward to seeing our next production. Sam, I don't know, we haven't determined it yet, right?
Yeah, it's the end of this
Yeah,
webinar.
we'll talk about it. So we'll see everyone next time. Stick
See you
around
all.
to
Thank you for joining.
network. Stick around.
Stick around.
Okay, thank you.
Okay, we stop.